Okay, guys, so let's start today's class. So today I'm going to continue where we left yesterday. So let's start with pulmonary edema. Now, pulmonary edema, the name itself, tells you there is a collection of free fluid inside the lung parenchyma. That means inside the alveoli. So when fluid collects inside the alveoli, we call it pulmonary edema. Now, what may be the cause of this? Now, the causes are very simple here. The most important causes are mentioned here in a group, okay, or in a separate heading. First is by increased hydrostatic pressure. Now, hydrostatic pressure is given by the column of blood inside the capillary, okay. So it is caused by left-sided heart failure, mitral valve diseases, both stenosis as well as regurgitation can lead to pulmonary edema. Even fluid overload can lead to pulmonary edema. In fact, any disease which are there on the left side of the heart can give rise to pulmonary edema because of back pressure development. That is called increased hydrostatic pressure. Now, another important cause is decreased oncotic pressure. Now, you all know oncotic pressure is maintained by albumin. Okay. Now, if that albumin is less in the serum or blood, that will lead to decreased oncotic pressure. So the common disorders are nephrotic syndrome, where a lot of protein is lost in the urine. Sometimes even nephritic syndrome can give rise to decreased oncotic pressure, but that is less likely because in nephritic syndrome, very less amount of protein will be lost. Another very important cause of decreased oncotic pressure is liver disease, because liver is the organ which synthesizes albumin. So if there is chronic liver disease like cirrhosis of the liver, okay, then definitely there will be decreased oncotic pressure. Now, the third important heading is increased capillary permeability, and that is mainly caused by infection. Okay, different type of infection inside the lung. The commonest one is pneumonia. Okay. Now, some drugs can also lead to increased capillary permeability. These are damaging to the lung. Bleomycin is anti-cancer drug, and heroin is a type of opioid analgesic. Shock. This is the effect of shock in the lung. We call it shock lung. And as a result of shock lung, ARDS occurs in the lung. This is called ARDS. Today I am going to talk about this. And even the radiation exposure can lead to increased capillary permeability and leakage of the fluid. Now, before I move further, I like to highlight one very important point here. In increased hydrostatic pressure and decreased oncotic pressure, okay, increased hydrostatic pressure and decreased oncotic pressure. So see there, this is increased hydrostatic pressure, there is decreased oncotic pressure. The fluid which collects is called transudate, and in increased capillary permeability, because of leakage of more protein, the fluid which collect is called exudate. Okay, I'm sure students know that already. Okay, so let's move further. Now we are talking about pathology lecture here. So gross and microscopic morphology are the very big part of pathology discussion. So how the lung looks in gross examination and microscopic examination. In gross examination, the lungs look heavy. Okay, they look heavy. They are wet, and the heaviness is usually worse in the lower lobe naturally because liquid always goes distally. And regarding the microscopic feature, there are present of heart failure cells. Now, these heart failure cells are hemosiderin laden macrophages. Now, what do you mean by that? Already inside the alveoli, the macrophages are present. Okay, they are present already inside the alveoli. These are called alveolar macrophages. Now, those alveolar macrophages will engulf hemosiderin pigment. This hemosiderin is an iron containing pigment which is derived from the blood. Okay, in blood there's a lot of iron, so that hemosiderin will be eaten by the macrophage and we call those type of macrophages as heart failure cells. So one common question which may be asked to you, heart failure cells are seen in which organ? Just to make you confused, never get confused. These heart failure cells are seen in lungs, not in other organ, because those alveolar macrophages are present only in the lung. Now, after this, let's talk about ARDS, or Adult Respiratory Distress Syndrome. ARDS. This is a very important, topic. The concept is important actually, and I will take a bit of time to discuss this. Now, these days, all of us, okay, all over the world, we are suffering from one pandemic, okay. Even in Pakistan, even in China, even in Nepal, everywhere we are dealing with that, okay. COVID-19. Now, one of the main way why COVID-19 kills the patient is causing ARDS, Adult Respiratory Distress Syndrome, or it is also known as Acute Respiratory Distress Syndrome. Okay, both are synonym. Now, what is happening here? There is diffuse damage in the alveoli, okay, because of the inflammation in this case. In COVID-19, it is because of inflammation. But in any type of shock, like hypovolemic shock, septic shock, anaphylactic shock, isn't it? Any other type of shock, lung can be damaged as one of the organ, and that is also known as shock lung, and shock lung also may lead to ARDS. Now, in this disorder, there is diffuse damage of alveolar epithelium, mainly the type 1 pneumocytes are damaged, but at the same time, even type 2 pneumocytes are also damaged. So there will be loss or lack of surfactant. Now, this disease is very, very important in the sense, if we give only oxygen, okay, if we give only oxygen, either through the mask or through the tube, the patient doesn't respond. Hypoxia, if we give only oxygen like that, we have to give oxygen with pressure. Pressure is very necessary here, because the fluid is collected inside the alveoli. Remember, that fluid is because of the leakage from the capillary. So this fluid is exudate. This fluid is heavy. I need to displace this fluid with some pressure, then only oxygen can diffuse there. So mechanical ventilator is the treatment in case of ARDS. Only oxygen is not going to help. Now, what are the causes of ARDS? Let's quickly list them. Shock, I already told you, any type of shock. Sepsis or infection. Trauma, major trauma in the body. Gastric aspiration. So this is a very important cause. Any gastric content, if aspirated inside the airway, it may reach the lung and it may lead to ARDS, because that gastric content has got HCl, or hydrochloric acid, and this hydrochloric acid is very damaging for the lung. Radiation exposure, okay, oxygen toxicity also can lead to ARDS. We all know oxygen is a type of drug actually, especially in the neonate. We don't want to give unnecessary oxygen if it is not required, because the oxygen itself can damage the lung. Drugs like bleomycin and heroin, we have just listed. Pulmonary infection, okay, like pneumonia, and many other causes are there. Near drowning is one of them. Near drowning, okay. Some poisoning, maybe other. So many other causes can be listed. Now, the clinical presentation in the patient would be, patient is severely dyspneic, okay. Patient is severely dyspneic. There is tachypnea. I'm sure you know what is tachypnea. This is the increased respiratory rate. Patient will have hypoxemia, or there is decreased oxygenation in the blood, which is called hypoxemia. Patient looks blue, that is cyanosis. And if I examine this patient, then the patient will use accessory muscles of respiration, because patient is having dyspnea. Okay. In yesterday's class, many students to answer me correctly. Those are sternocleidomastoid, trapezius, intercostal muscles, and even the anterior abdominal wall muscles. So all of them may be used. Now, if we take X-ray, there is a collection of fluid on both lung. So both lung looks white. So we call it white out lungs or bilateral opacification of the lung. This is important feature in X-ray. Now see here, what happens if we examine gross and microscopically? What happens? What type of feature we see in the lung? Okay, now see here, grossly it is almost like pulmonary edema. This is actually speaking pulmonary edema, but there is one difference from the cardiogenic pulmonary edema. It is known as non-cardiogenic pulmonary edema because heart disease are not causing ARDS. Some other disorders or diseases are causing ARDS. So we also call it as a non-cardiogenic pulmonary edema. Some of the books have mentioned like that. Now, microscopic appearance would be there is interstitial and intraalveolar edema. That's why we call it pulmonary edema. There is inflammation going on in the interstitial space, loss of type 1 pneumocyte, and there is hyaline membrane formation. Now, in yesterday's class also, I talked a little bit about it. Hyaline membrane is formed when there is no surfactant, and surfactant is produced by type 2 pneumocyte. So in this case, type 2 pneumocytes are also damaged. As a result of this, hyaline membrane is formed. Okay, so this is an important knowledge here. Now look at this picture. I like to use some spotlight here. Here now on this side there is a normal alveolus. Okay, see that this is bronchial epithelium. Probably this is respiratory bronchial. After that, alveolar duct and alveoli will start. So this is the lining of the alveoli. A type 1 pneumocyte, a type 1 alveolar cell. Okay, this is type 2 alveolar cell, and type 1 are the major cells. Type 2 are scattered here and there, and inside the alveoli, alveolar macrophage is present. So this is a normal. Okay, from this line to the right hand side. Okay, this is normal thing. Now on this side, damage has been happened. There is acute lung injury and a lot of changes are going on here. See here, there is sloughing of the bronchial epithelium. The type 1 cell is necrotic. Okay, edematous fluid has come inside. There is collection of cellular debris. Okay, this is known as waste product. As a result of inflammation, the neutrophils, okay, which are present inside the capillary will migrate towards that inflamed area. Okay, they will come inside the alveoli and they are activated. Okay, they are activated because of alveolar macrophage which secretes different cytokine, or they are the cells of first line defense. So whenever they come into that area, they are activated by themselves as well. So they release different type of chemical mediator like leukotrienes, proteolytic enzyme or protease, platelet activating factor, and that can lead to increased capillary permeability again. Okay, they can lead to migration of more inflammatory cells there, and all of these lead to excessive collection of fluid inside the alveoli, which is known as ARDS. Okay, so there is one short form MIF. That MIF is macrophage migration inhibiting factor. Okay, this is another type of cytokine. Okay, so let's move on. Now, one small point I like to highlight before I go to the obstructive airway disease. Okay, so what is the treatment of ARDS? If somebody asks you, then you should say we must give oxygen with the help of mechanical ventilator. You have to give oxygen, definitely. There is hypoxemia going on, but only giving oxygen through the mask or through the tube is not going to be enough. You have to push that oxygen inside with the help of mechanical ventilator. First answer. Second, what is the cause of this ARDS? Let's find it out and go for the treatment. Now, I'm going into a very important topic which is known as obstructive airway disease. COPD comes under this heading. Now, let's start with a meaning or definition. Now, definition of obstructive airway disease would be there is increased resistance to airflow secondary to obstruction of airway. Okay? Now, this obstruction mainly occurs during the expiratory phase. Now, ventilation has two phases, inspiration and expiration. More resistance occurs during expiration in case of obstructive airway disease. That's why the air remains inside the lung. Now, what that air will do to the lung? It will make lung bigger in size. So whenever you examine that type of person, you will feel the ears are bigger than normal and they push the diaphragm below. Okay, when diaphragm is pushed below, both spleen and liver will also be pushed downwards. So in this type of people, liver may be palpable. Okay, we'll talk about that later also. Now yesterday we talked about pulmonary function test, which is known as spirometry. Now remember all these terms you discussed yesterday. FEV1, force expiratory volume in 1 second. Okay, force expiratory volume in 1 second. See here? You see this? This is the force expiratory volume in 1 second. If I take the ratio of FEV1 to FVC, this is force vital capacity, the ratio is less than 70 in case of obstructive airway disease. It is less than 70. Normal people, it is more than 80. But in case of obstructive airway disease, it is less than 70. This is a very important diagnostic point. Now, what are the examples of chronic obstructive airway disease? Now, the common example many students know already. Okay, they are asthma, also known as bronchial asthma, chronic bronchitis, and emphysema. Chronic bronchitis and emphysema are examples of COPD or chronic obstructive pulmonary disease, and that is the major topic what we discuss in today's class. Now, so I have copied the same slide, okay, similar type of slide I should say, just to make you understand in a better way. Now see here, what do you mean by this FEV1 to FVC ratio? See here, this is FEV1, okay, FVC in normal lung, okay. Now see there, in obstructive diseases, look here in obstructive disease, FEV1 is also very low, FVC is also very low. Normally they should be here, but in this condition they are way below. That means both are severely decreased. This is a very, very important knowledge. And this is the picture which we discussed yesterday as well. Now, on other hand, what is restrictive lung disease? Okay, what do you mean by restrictive lung disease then? Okay, see there. Now, restrictive lung disease is the opposite of obstructive lung disease. In this condition, the total lung is either contracted or damaged. So there is decreased lung volume and capacity. If we do pulmonary function test or spirometry, the total lung capacity is reduced and vital capacity is also reduced because the total lung size itself is less. And the common examples of restrictive lung diseases are either chest wall disorder or interstitial infiltrative disease. Now, chest wall disorder, this means the chest wall is not expanding. During inspiration, remember, the chest wall would go outwards so that there is increased space development inside the thoracic cavity. This is the reason why negative pressure would develop inside the thoracic cavity, right? Because of this, inspiration occurs. But think about the situation here. If these conditions doesn't allow chest wall to move outward, they will constantly compress the lung, resulting in restriction of the lung. Now it is very clear to you, obesity is one of the condition. Obesity, there is fat everywhere. Kyphoscoliosis is a disorder of vertebra. Now kyphosis is backward bending of the vertebra, and scoliosis means side way bending. So combination of backward and sideward bending is kyphoscoliosis. Ankylosing spondylitis is a disorder of the joints, especially the vertebra joints. Okay, intervertebral joints are seriously affected, and another important joint is sacroiliac joint. These are very badly affected in this condition, and ultimately towards the end stage of the disease, the vertebra is fixed. Okay, there is no movement in the vertebra, there is no flexion at all. It looks like a bamboo, so we also call it as a bamboo spine. Okay, bamboo spine. So let me write that bamboo spine term here. Maybe you may want to know about this. Okay, so bamboo spine is seen in case of ankylosing spondylitis. Okay, bamboo spine. Okay, so let me erase this, otherwise it will disturb us. Fine. Now, some of the interstitial infiltrative disease, means interstitium of the lung are infiltrated by different materials. ARDS, which we just discussed, because there is exudative fluid which is infiltrating there. Pneumoconiosis means dust related lung disorders. Okay, and pulmonary fibrosis is a contracting lung disease. Okay, there is fibrosis going on inside the lung. So all of these are the examples. Now, with this information, let's talk about COPD, chronic obstructive pulmonary disease, or in some of the textbook, it is also written as COAD, COAD, chronic obstructive airway disease. So both are absolutely same. Now, we already know this COPD or COAD have mainly two types: chronic bronchitis and emphysema. Chronic bronchitis and emphysema. So let's start with chronic bronchitis discussion and move on to the emphysema. Now, the definition of chronic bronchitis is a clinical one. You need to take history to define chronic bronchitis. So you need to ask two questions here. How long are you coughing? Okay, how long are you coughing? And is there any sputum along with cough or not? If the patient say yes, and the second question you will ask, how long, how many months, how many years, you ask that. So if the patient say, I have been coughing along with copious means more, sputum production for at least 3 months in 2 consecutive years, okay, the definition of chronic bronchitis is fulfilled. So it is very easy type of definition. So let me highlight here once again: persistent cough and copious sputum production for at least 3 months in 2 consecutive years. 3 months in 1 year, and if that goes on for 2 consecutive years, okay, 3 months in 1 year, and if that continues for 2 consecutive years, the diagnosis of chronic bronchitis is done. Okay, now see here. Now, it is highly associated with smoking. Almost 90% of the cases of chronic bronchitis are because of smoking. So we should, or we must take the history of smoking all the time if we are thinking about COPD. Now, what are the source of smoking? I like to highlight a little bit here. The number one source of smoking is cigarette smoke. Okay, cigarette smoke, and a lot of people are smoking cigarette these days. Not only the male, also female are smoking these days. Okay, so a lot of female, they are also having COPD. That is number one source. Number two source of smoking is household smoke. Household smoke, and mainly females are suffering from this. The third one is passive smoke. Passive smoke means one friend is smoking very nicely in the room. Okay, he is enjoying the smoking actually, and many other student I should not say student here. I don't want to raise my finger to you guys. It may be applicable anywhere. Okay, other people who do not smoke, there just getting the effect of the smoking in free of the cost. They are not doing anything, but they are getting the harmful effect of smoking. So passive smoking is another type or source of smoke. The last one I like to highlight here is city smoke. because of pollution. So many people these days are getting lung diseases. They never smoke in their life, no cigarette smoking at all, but they are having this COPD, and that is because of city smoke, because of pollution. Okay, so let's move on. Now, what are the clinical findings in case of chronic bronchitis? I already told you there is cough with sputum production. Okay, this sputum production is more than the normal. It is a bit of massive type. There is difficulty to breathe, which is called dyspnea, and this chronic bronchitis has frequent chest infection. This person keep on coming to the hospital with repeated chest infection. We admit them for few days, give some antibiotic and discharge again, and after few months they will come back again. This is the a pattern of chronic bronchitis. At the same time, these people, they suffer from hypoxia. Okay, they suffer from hypoxia, cyanosis, and weight gain. Now, these are the very important point I like to highlight here. Hypoxia is very easy to explain because the airways are obstructed, isn't it? So hypoxia will occur, and because of this hypoxia, cyanosis is also quite common. Now, in cardiovascular system, I have not taken your class in cardiovascular system like this, so I'm not sure whether you know this point or not. When there is chronic hypoxia, okay, when there is chronic hypoxia, what changes occur inside the lung regarding blood vessels inside the lung or pulmonary blood vessels in all over the body? Okay, the systemic blood vessel will become dilated because of the effect of hypoxia, but inside the lung the blood vessels will be constricted. This is pulmonary vasoconstriction. As a result of pulmonary vasoconstriction, there is excessive pressure buildup inside the right ventricle. Listen very carefully. The right ventricle will feel a lot of pressure. Now with this pressure, right ventricle will hypertrophy. Okay, it will become hypertrophy, and ultimately right ventricle fails. This is called cor pulmonale. Cor pulmonale, and because of this cor pulmonale, patient will develop edema, and this edema leads to weight gain. Okay, weight gain. This is how we need to explain. So chronic bronchitis patients are usually edematous and they are cyanose with a bit of weight gain. Now, before our time is over, I like to quickly do this. Okay, after 40 minutes, it will be disconnected and we need to reconnect again. So see there, what is happening in chronic bronchitis? There is injury in the wall of the bronchi or bronchioles. So bronchospasm is going on. Spasm means narrowness of the bronchi or bronchus. There is hypersecretion of mucus occurs, and there is repeated infection. So with the effect of all these three things, okay, chronic bronchitis disease occur. Chronic bronchitis disease occur. On the other hand, destruction of alveolar wall, okay, or alveolar septum leads to emphysema, and a same patient may be having both of these conditions together. That's why we call it COPD. Now, the patient may not have only one of the spectrum. They may be having both conditions together, chronic bronchitis and emphysema. Okay. Now, what are the microscopic features of chronic bronchitis? If we take a biopsy from the airway, what we see there? Okay, let's talk about this. There may be hypertrophy of the bronchial mucus gland because of repeated stimulation. As a result of smoking, they become hypertrophied. There is increased number of goblet cells, which also helps in excessive mucus production, and that mucus will result in excessive sputum. There is squamous. Okay, so let's start again. Okay, now before the break, I was talking about microscopic features of chronic bronchitis, what happens in the airway. So let's continue. Now, because of the constant irritation by smoke or smoking or cigarette smoking, which is the most common source, there is hypertrophy of both bronchial mucus gland as well as increased number of goblet cells. Now remember, in chronic bronchitis, what is happening? There is increased amount of sputum. Okay, there is increased amount of sputum production. Now, the source of this sputum, okay, is because of this excessive secretion from either a bronchial mucus gland or goblet cells. Along with that, even the infection plays the role. Now, because of constant stimulation, the bronchial epithelium will change. Now, what is the normal epithelium of the bronchus? You can unmute yourself and answer this. What is the normal epithelium of bronchus?
Pseudostratified columnar epithelium.
Very good. Pseudostratified. Yes.
Pseudostratified column.
Very good. Okay. Pseudostratified ciliated columnar epithelium. Excellent. Now, what is happening? Because of the chronic irritation by smoking, this epithelium will change into the squamous epithelium. So we call it squamous metaplasia. And over a long run, this squamous metaplasia may develop into the cancer. We call it bronchogenic carcinoma. This is important information for you. Now, what complication can happen in chronic bronchitis? Now, see there is increased risk for recurrent chest infection. Because of this, patient keep on coming to the hospital and gets admitted. Cor pulmonale is a very important complication. I already explained the mechanism there. Because of chronic hypoxia, there occurs pulmonary vasoconstriction leading to pulmonary hypertension. Now, because of that pulmonary hypertension, right ventricle fails, which is known as cor pulmonale. Because of cor pulmonale, the person will develop edema, and the person is already cyanosed because of chronic hypoxia. So if I combine this edema, okay, and cyanosis, we call these people as blue bloaters. Blue is the term for cyanosis. Bloaters means they are swollen up, they are edematous. So chronic bronchitis people are blue bloaters. This is very important information, and in the exam we love to ask this: what's the meaning of blue bloaters? Okay, and many of the people may develop lung cancer as well. This lung cancer is because of squamous metaplasia of the bronchial epithelium. Now see here, this is the histopathology of the airway in case of chronic bronchitis. Histopathology of the airway. Now look at these cells here. Okay, these all are massively increased number of cells. They become hypertrophied as well. Okay? Both hyperplasia as well as hypertrophy is seen. And look at this type of epithelium. This is called squamous epithelium. Usually the airway doesn't have this type of epithelium. Okay, so this is called squamous metaplasia of the bronchus, which is caused by long-term smoking effect. Now, after we are done with chronic bronchitis, let's talk about emphysema, another very important type of COPD. Now, what is the meaning of emphysema first? Okay, have a look there. Emphysema means the alveolar septa are destroyed. There are alveolar septa which are separating the alveoli. Now, because of some etiology, this alveolar septa are destroyed. So many alveoli, they fuse with each other now. Or in other words, there is a large air space which is synthesized. And where is this air space now? Distal to the terminal bronchiole. Now, I want to discuss a bit of yesterday's discussion again. Respiratory bronchiole, alveolar duct, and the alveoli. Okay, this is called acinus of the lung. This acinus is a working unit of the lung. Now this emphysema disease is damaging this acinus of the lung. So distal to the terminal bronchiole, respiratory bronchiole, alveolar duct and the alveoli, all of these are affected in emphysema. And as a result of destruction of alveolar septa, there is loss of elastic recoil function of the lung. Now, for expiration to occur, elastic recoil of the lung is very important property. So with the loss of elastic recoil property, expiration is a problem. Now without proper expiration, what happens to the air which is collected inside the lung? It will remain there, isn't it? There is over distension of the lung. This is a very important feature in emphysema. Just print this knowledge in your mind. Emphysema means over distended lung. The lungs become huge. Okay, this is very important point. Now let's talk about etiopathogenesis. What are the etiology and what is the pathogenesis in a combined way? There is imbalance of protease and antiprotease enzyme inside the lung. So protease means proteolytic enzyme. They eat or break down the protein, and antiprotease will antagonize that. So in any organ, both of these should be in balance. But if proteases are more and if antiproteases are less, then more proteins would be eaten or destroyed, leading to severe damage of that organ. Now let's talk about emphysema here. These alveolar septa, okay, are having a lot of protein. These proteolytic enzymes are damaging these alveolar septa, leading to emphysema. Now you already got the meaning. So in this case, proteases or proteolytic enzymes are more than antiprotease. Now what are the source of this protease? Okay, let's talk about it. This protease, one of the protease is elastase, and they are produced by neutrophils and macrophages. And these neutrophils and macrophages are reaching there, okay, because of inflammation. Antiprotease include alpha-1 antitrypsin, alpha-1 macroglobulin, and secretory leukoprotease inhibitor. But among them, the most important one is alpha-1 antitrypsin. That's why if there is alpha-1 antitrypsin deficiency inside the body or in the lung, okay, only protease will be more, and this is one of the cause of emphysema. This alpha-1 antitrypsin deficiency may run in the family as an autosomal recessive disorder. So different member of the same family may be affected. Remember, autosomal recessive disorder have 25% chance, okay, of recurring in every pregnancy. So this is a very important knowledge. One more thing I like to highlight here, even liver is badly affected by alpha-1 antitrypsin deficiency, and inside the liver it can lead to cirrhosis of the liver. Now this particular part I like to take a bit of time and explain. Okay, see here. See here. This is a capillary. Inside the capillary, these are neutrophils. Look, there are 3 nuclei there. Okay, these are neutrophils. Now, what is happening inside the alveoli? This is alveoli. Okay, this is alveoli. See here. So this is alveolar macrophage present here, which is naturally present. Because of chronic smoking, there is liberation of free radicals. Okay, this liberation of free radical, they inactivate the antiprotease, means antiproteolytic enzyme are inactivated by chronic smoking with the help of free radicals. Now already we have decreased level of antiprotease. At the same time, because of this migration of neutrophil in that area where it is an inflammation going on, neutrophil elastase is released. Now this elastase is a type of protease now. So protease are more and antiprotease are less already. Okay, this is one important point. Another, on top of this, if this patient is congenitally deficient in alpha-1 antitrypsin, they are more vulnerable for the damage of this proteolytic enzyme. So all of these combine together and severely destroy the alveolar septa, leading to emphysema. So this is how you understand the pathogenesis. Now, after going through those pathogenesis, let's talk about the types of emphysema. What are the types? How many types are there? Okay. Now, they are centriacinar, panacinar, distal acinar, and irregular. Now, once again, I like to highlight the meaning of acinus. Okay, what is acinus now? Acinus is a combination of respiratory bronchial, alveolar duct, and alveoli. So, your mind should be there now, okay, at that part. Now, centriacinar, also known as centrilobular, in this condition, the proximal respiratory bronchioles are involved and distal alveoli are spared. So that means the respiratory bronchial side, which is upper side or proximal side, is affected, but the distal alveoli are not affected in this condition. This is the most common type of emphysema. Almost 95% of the patients are having it, and it is strongly associated with smoking. Okay, it is strongly associated with smoking, and the distribution is worst in apical segment of upper lobe. Means upper lobes are mainly affected in centriacinar. Next slide will again highlight this. Let me finish this first. Another type is panacinar or panlobular, and alpha-1 antitrypsin deficiency because of the hereditary condition or because of genetic defect leads to panacinar emphysema. So you can highlight this, okay, or you can copy this in your notebook. This is a very important MCQ question which may be asked in the exam. Alpha-1 antitrypsin deficiency because of genetic defect or genetic disease leads to panacinar type of emphysema. So pan means whole or entire. So entire acinus is involved here. Is it? It may be respiratory bronchial, alveolar duct, or alveoli. Regarding the distribution, okay, this is worst in the bases of lower lobe. So exactly opposite of centriacinar. Another type is called distal acinar. It is towards the alveoli of the distal side or far away side, and irregular means patchy involvement here and there. Patchy is called irregular. So centriacinar, which is most common, panacinar, entire acinus is involved, distal acinar towards the alveoli, and irregular is a patchy one. Now let's see some of the picture here. Okay, now see this. Sorry, I'm going now. Let's focus here now. See here, this is the normal acinus. So this is respiratory bronchial, this is alveolar duct, and these are the alveoli. Respiratory bronchial, alveolar duct, and alveoli. Now what happens in case of centriacinar? See this. This is the respiratory bronchial side. So towards the respiratory bronchial side, there is dilation. Means the expansion occurring towards the proximal area. This is called proximal site. Very easy to understand. Now panacinar means almost the whole of the acinus is affected, even the respiratory bronchial, alveolar duct, and alveoli. Okay, and distal acinar, which is not shown here, but this is distal acinar. If only this is involved, this is called distal acinar. And patchy means maybe a small area here, a bit of here and here. So irregular type of distribution. Okay, let's move on. Now if I examine the lung, how the lung looks, okay, what are the gross morphology of the lung? Naturally they are overinflated. Now why are they overinflated? Because there is collection of large amount of air. That lung is changing into a cyst-like appearance. Grossly visible air spaces are seen if we cut the lung, and in centriacinar type we can see the formation of bleb towards the apex area of the lung. Bleb means smaller, bulla means larger. Okay, These are the cyst-like appearance in the upper part of the lung or upper lobe of the lung. Now, regarding the clinical findings in emphysema, the person will have progressive dyspnea and hyperventilation. Dyspnea is increasing day by day because lung is getting destroyed from inside, and the person will have increased rate of breathing. These type of patients are not cyanosed until very late in the disease course. Okay, what's the explanation for this? Now, cyanosis will not occur if there is adequate oxygenation in the blood, and that happens in case of emphysema. So blood gas values are relatively normal here. Okay, the PaO2 doesn't fall that drastically. So as a result of this, these patients are not blue, but okay, they look still pink. Pink means there is adequate oxygenation in the blood, but they are very dyspneic. So when they breathe, okay, they purse their lips together, and they also use accessory muscle to breathe out. Because of this reason, they are known as pink puffer. Now let me explain once again. Pink means they are not blue. Okay, they are still having good oxygen content in the blood. Puffer means when they breathe out, they bring their lips together, and at the same time they use a lot of accessory muscles to breathe out. So they are called pink puffer. Chronic bronchitis patients are called blue bloater, while as emphysema patients are called pink puffer. Okay. Now, when we examine their chest, because of the over expansion of the lung, the chest wall looks huge. Okay. At the same time, it looks rounded. Now, normally, remember, normally there are two important, diameter of our chest. One is called transverse diameter, and another is called AP, or antero-posterior diameter. Now, in normal people, transverse diameter is more than AP diameter. But what happens in case of emphysema, both diameter are almost the same. So because of this, the chest wall look rounded like a cylinder, like a barrel. That's why it is known as barrel chest. Very important feature of emphysema. These patients lose weight. This is a chronic disorder, and this patient lose weight, which is another important difference between a chronic bronchitis and emphysema. In chronic bronchitis, because of edema, because of heart failure, they gain weight, but gaining in weight is all edema. Okay, it is not muscle mass. In this case, they lose muscle mass. They become very lean and thin. Now look at the morphology. Okay, this is the gross morphology, and this is the microscopic. Okay. Now see here, I like to highlight this and show to you. See here. Okay, let's talk about the gross first. See this blebs and bulla. See here, these are called bulla, which are present in the apex area of the lung or upper part of the lung. So this is centriacinar emphysema. This is centriacinar emphysema. In the exam, in the pathology exam, if exam occurs, they are not only in my exam, anywhere, wherever you go, this type of pictures may be shown to you, and they ask what type of emphysema is this, or what type of disease is this. Now you see it very carefully. Okay, use your knowledge and answer this. This is centriacinar emphysema. Now this is a microscopic appearance. Okay, if we take a biopsy from the lung looks like this. Look here, there is a very large air space which is developed inside the lung. This air space occurs because of destruction of alveolar septa. Okay, a lot of alveoli join together with each other and form bigger air space. This is a very important feature. Okay. Now let's move on. At the end, let's differentiate chronic bronchitis from emphysema. Okay. Now I'll give you 1 to 2 minute time. Okay. I'm sure all of you can see it very clearly. So can you please go through it? Then I'll discuss one after other. Okay. See that, please. Okay, now see. So let me explain now. Now look at the age. Chronic bronchitis patients are usually, they start, okay, even the older patient may present with chronic bronchitis, that's not the meaning, but the initiation of the disease may occur from the age of 40 to 45, whereas emphysema patients are a little bit older. Regarding the dyspnea, in emphysema it is severe and it is early, but in case of chronic bronchitis it is mild and it is late. It occurs late in the course. That is difficulty to breathe. Regarding cough and sputum, it occurs quite early in the disease and there is massive amount of sputum production. This is called copious sputum. And in case of emphysema, okay, cough and sputum production occurs very late and there is scanty amount of sputum, very less amount of sputum production or not produced at all. Okay, cough also occurs very late. Infections are quite common in bronchitis, very occasional in emphysema, so it is not an important point in emphysema. Respiratory failure, insufficiency means failure, repeated in case of bronchitis, and terminal in case of emphysema. When the patient is very sick, okay, when the disease occurs for a long time, then only respiratory failure occurs. Cor pulmonale is very common in chronic bronchitis. That's why these people are blue bloaters. But in emphysema, cyanosis is not common at all. Okay, even if it occurs in the terminal stage. Okay, very late. Resistance of the airway is increased in bronchitis, but in emphysema, because it is a disease mainly of alveolar duct and alveoli, only the respiratory bronchiole is affected here. The resistance to the airway is normal or slightly increased because of respiratory bronchial involvement. Elastic recoil is very low in emphysema. Remember, it is the disease of elastic recoil or decreased elastic recoil, which is normal in bronchitis. If we take chest X-ray, the lungs are hyperinflated in emphysema, okay, and heart looks quite smaller or tubular heart we say, because that heart is compressed by the inflated lung on both sides. But in bronchitis, there is prominent blood vessels seen inside the lung, okay, and heart looks big in size because of heart failure. That heart failure is known as cor pulmonale, you all know that. And appearance from outside, they look blue and they are bloated. This bloated term is for edema, and in case of emphysema, they are pink puffer. Okay, blue bloater and pink puffer. Okay, with this, okay, we have come towards the end of this topic. So at the end, these questions I have prepared. I've already given this question to you. Okay, students, so let's start the class for today. Today also I'm going to talk about bronchial asthma in the beginning. Then after that, I go on to the discussion of bronchiectasis and finally pneumonia. So yesterday we were talking bronchial asthma, so quickly revise it, okay? Now, regarding the definition of bronchial asthma, in this disorder, the airways become hyperreactive, and because of this, there is episodic bronchospasm when triggered by certain stimuli. Now, this disease is usually associated with chronic inflammation of the airway. That's why if we can stop that inflammation by giving certain drugs, okay, I'm talking about corticosteroids here. They are the mainstay of therapy these days. Then the bronchial asthma incidence will be much less. Though in pathology we don't talk about the management or treatment, but sometimes it is necessary. If I explain like that, you can understand in a better way. And one more thing, the spasm or the airway spasm in bronchial asthma is reversible with the use of bronchodilator drugs. The most important bronchodilator here are salbutamol, terbutaline, and one of the antimuscarinic drug. Okay, you already know the name, ipratropium bromide. They are very commonly used. Now, there are two types of bronchial asthma according to the pathological textbook. There are extrinsic asthma and intrinsic asthma. Now, extrinsic asthma is caused by type 1 hypersensitivity reaction. And intrinsic asthma, though there are a lot of hypotheses or presumption, we actually do not know the exact mechanism. Okay, I will talk a little bit later. Now, extrinsic is also known as allergic or atopic asthma, which is the most common type in comparison to the other. In this condition or in this type, the bronchial asthma attack occurs from the early childhood. So, children and young adults are mainly suffering. Okay, children and young adults are mainly suffering, and there is very strong family history present. Means multiple members in the family may be having similar type of condition. And one more thing I like to highlight right here, the same patient may be having other component of type 1 hypersensitivity reaction, like like allergic rhinitis. Allergic rhinitis, also known as hay fever. And in this condition, the person has a frequent sneezing with nasal discharge. Another condition is allergic conjunctivitis. That is red eye. This is another type of type 1 hypersensitivity reaction which can occur in the same person. The third one affects the skin now. It is known as atopic dermatitis. Dermatitis means inflammation of the skin. So atopic dermatitis. So you should know these things, because this is one of the common question from the examiner side. The question may come like, what are the other common type 1 hypersensitivity reaction example? So along with bronchial asthma, these are the ones. Now, this is allergic asthma, so some allergens are responsible for the attack, and the common examples of those allergens would be pollen, pollen, dust particle, even food particle, molds. These molds means they are the yeast, animal dander or animal excreta. The notorious one are the insect which are present inside the household. And sometimes the person who are working in the factories or industries, they are often predisposed to fumes, gases, and different chemicals. They may be responsible. Now, the other variety of bronchial asthma is non-atopic or intrinsic or idiosyncratic asthma. I already told you the exact mechanism at the molecular level is unknown, but we have certain hypothesis or presumption. One of the cause of intrinsic asthma may be viral infection of the respiratory tract. Now, the common hypothesis or presumption here, why this causes asthma attack is, they decrease the threshold of subepithelial vagal receptors to the irritants, which is clearly written here. If you follow this, it lowers the threshold of subepithelial vagal receptors to irritant. Now, the vagus nerve is a parasympathetic nerve, and the function of parasympathetic receptor in our airway is contraction. It contracts the airway, or it makes the airway narrow. So if there is decreased threshold, means even with a smaller amount of stimulus, if these vagal receptors are irritated or stimulated, there will be early contraction of the airway. So that is just the hypothesis. Let me repeat once again. Stress, exercise, and cold temperature, all of these, according to the hypothesis, it is believed that they also decreases the threshold level. That means they make the airway more hyper responsive. You can understand like this. They make the airway more hyper responsive. And the last one is aspirin. It's one of the member of NSAID family. Very important member of NSAID family. And though exactly we don't know what is the mechanism, but again, let me clarify something with you. You all know how aspirin acts. Aspirin blocks cyclooxygenase enzyme, isn't it? And the compound which is present are formed after cyclooxygenase pathway is, which compound is formed after cyclooxygenase pathway? Very good. You can simply say prostaglandins. Okay, excellent, prostaglandins. Now, because of the blockage of that enzyme, prostaglandins are not formed, and the pathway will be diverted towards leukotriene pathway, because another enzyme is lipooxygenase, which is not blocked by aspirin. So that leukotrienes may be causing narrowness of the airway. Okay, so this is one of the hypotheses they have given. If you study different textbook or different internet site, that point may be found. Let's move further now. Okay, I don't go to the differences between these things. We have already done yesterday, and I'm sure you have already got the meaning. Okay, so let's talk about what is the pathogenesis of extrinsic asthma now, because this is a well proven. Extrinsic asthma is caused by allergy or type 1 hypersensitivity reaction. So let me explain this in detail. Okay, now let me use this one. Fine. Now see here, this is the normal airway. You can see this is the normal airway. Okay, this is an airway, and here they have shown in a bigger picture. So this is the lumen of the airway. Okay, the lumen of the airway. Now one pollen or antigen has come inside the lumen. This is a pollen or allergen or antigen. Now it is picked by antigen presenting cell. In this case, it is a dendritic cell. This dendritic cell has picked the antigen. Now the function of this antigen presenting cell is, after picking the antigen, it will process the antigen. That means the bigger antigen will be degraded into a smaller one, and then with the help of MHC type 2 molecule, this antigen will be presented to the T cell. Never forget this. This is a very important point you got from immunology. Now, that T cell is called naive T cell till now, but after it gets stimulated, it will differentiate into Th2 and Th1 type of cell. Now, in this condition, we are talking about bronchial asthma or allergic disease. So, Th2 cell will be formed. Now, this is also known as, you can say, T helper type 2 cell. Now, this T helper type 2 cell will release different cytokines. Okay, one of the important cytokine is interleukin 4, another maybe interleukin 3 and interleukin 5. So they will stimulate some other cells of the immune system, like B cell. Okay, B cell. That B cell will turn into plasma cell, and that plasma cell will synthesize IgE antibody. Now this is allergic disease, so the antibody which is formed is IgE. Now what happened? This IgE antibody will go and attach itself on the surface of mast cells. Now these mast cells are present in the submucosal area of the airway. Okay. Now this stage, okay, this stage when IgE antibody are attached on the surface of the mast cell is called sensitization. Sensitization. Okay, remember that. Wait. Okay. Now this is called sensitization. Now then after that, what happens now? Now for hypersensitivity reaction to occur, we need second exposure. Okay, we need second exposure. Now for example, the second exposure has occurred. Okay, after the second exposure occurred, there will be cross-linking. Okay, there will be cross-linking between these, this IgE antibody, and after cross-linking occurs, they will degranulate. Means these mast cells will rupture or degranulate, and what the preformed mediators which are already there would come out. Some of the important preformed mediators here are histamine and bradykinin. Histamine plays a major role here, and it quickly leads to a lot of the effects. Okay, it can lead to increased secretion, okay, it can lead to airway narrowing and all those things. Now after some time, which is called late phase reaction, okay, the other inflammatory cells will come into the picture. Now important other cells are eosinophil, okay, even the neutrophil, and they release different cytokines like leukotrienes. Leukotrienes are very important cytokines which comes in late phase reaction. So if you understand like this, okay, it will be very easy for you. So in the subsequent slide, I will repeat the same concept once again. Now here, regarding the pathogenesis of asthma, okay, it is IgE mediated disorders. Now this IgE is synthesized by plasma cell because these are atopic individual. Atopic individual, after they are predisposed to the antigen, they synthesize IgE antibody. But non-atopic individuals, means other normal people, okay, who are not sensitive to allergy, they do not synthesize IgE antibody. Remember that. They synthesize IgG or IgA antibody when they predispose themselves to the antigen. This is a big difference between atopic and non-atopic individual. Now this IgE, okay, get attached on the surface of the mast cells on the mucosal and submucosal surface. Now these mast cells will degranulate, okay, degranulate, and chemical mediators like histamine, leukotrienes, okay, leukotrienes are less important in the early phase, more important in the late phase actually. Platelet activating factor and other chemoattractive factor would be released. Now look at this. The net effects of these mediators are bronchoconstriction, very, very important point. That's why asthma patient will have difficulty to breathe. Edema of the airway, it will further narrow the airway. Hypersecretion of the mucus, it will further narrow the airway because of excessive collection of the mucus inside the airway lumen. And accumulation of eosinophil and neutrophils. That's why if I examine the sputum of a patient of bronchial asthma, I will get a lot of eosinophil deposition simply on the sputum. Neutrophils can also be there, but they are less important than eosinophil. Now what happens in late phase? Okay, let's talk about what happens in late phase now. Okay, wait, some of the students want to join, so let me accept them first. Okay, now late phase reaction, it follows the acute immediate response and it is responsible for the prolonged manifestations of asthma. Now I like to give some practical points immediately here. Now you are working in the hospital, in the emergency room. One patient comes with severe difficulty to breathe because of asthma attack. You have given salbutamol and the patient gets better, but don't be happy, okay? Don't be happy and don't discharge the patient immediately, because that difficulty to breathe was because of immediate reaction. The late phase reaction is still going to happen. So if you discharge this patient early, when he reaches home or when she reaches home, then that time that late phase reaction will occur and they will have problem there. So it is highly advisable to admit this patient for at least 24 hours in the hospital once they come with the attack of bronchial asthma. And if the examiner asks why you want to do this, your answer is very easy, because that late phase reaction occurs after many hours. Okay, just to cover that up in the hospital, we need to admit this type of patient. Now what happens in late phase reaction? It is caused by excessive mobilization of blood leukocyte, which include basophil, eosinophil, and neutrophils. These eosinophils come in early phase reaction as well. Okay, and all the effect which happen in the early phase, like bronchoconstriction, edema of the airway, excessive mucus production and deposition in the airway, all those will be even seriously happen in late phase reaction. Now let's move further. What happens? Okay, what are the clinical features in asthma attack? What do you mean by asthma attack? Now see here, the patient comes to the hospital with severe dyspnea. There's no doubt about it. Dyspnea means difficulty in breathing. Another is wheezing. Now wheezing is called musical sound when somebody is breathing, and this wheezing occurs because of narrowness of the smaller airway. Now after the airway are contracted or become smaller, when air passes through those smaller airway, one sound will form, and that is called wheeze. So it is highly typical of obstructive airway disease like bronchial asthma. Cough is a very typical feature, there's no doubt about it, and some of the patient continuously having severe dyspnea and wheezing, okay, and they become very breathless, and they become very hypoxic as well, and sometimes they even develop coma. This is called status asthmaticus. Okay, status asthmaticus. This is a very fatal attack of bronchial asthma, and sometimes a patient may even die because of this. The treatment is same. You don't need to change your line of management. You still start with salbutamol nebulization, okay? Then repeat the nebulization if it doesn't work. If that salbutamol doesn't work, you need to add ipratropium bromide. If that doesn't work properly, you need to add aminophylline or theophylline. If that doesn't work, you can give a shot of corticosteroid like hydrocortisone. So the management is still the same, but we need to be careful. Now what happens in sputum cytology? What types of structures are seen if we analyze the sputum, okay, in case of bronchial asthma? Now these terms are very important from the exam point of view. These are called Kurzman spirals, okay, and Charcot-Leyden crystals. Now Kurzman spiral means they are the twisted mucus plug which are mixed with sloughed epithelium. Okay, they are mixed with sloughed epithelium. A twisted mucus plug mixed with sloughed epithelium. Sloughed means some of the epithelial cells fall into the lumen of the airway. So the mucus plug and those epithelial cells, they are twisted together and form Kurzman spiral. Lot of eosinophils are also present in the sputum, which we can detect by microscopy. And Charcot-Leyden crystal means these are eosinophil membrane protein. They are highly important MCQ question in any exam. Let me show you one picture here, okay? Please have a look here. Now see this, okay? Now these are the eosinophil. You can clearly identify the eosinophil, though it's a schematic diagram. It is not a real cytological picture, but it gives us the concept. Eosinophils, okay? This is also eosinophil. But here is the neutrophil. This is neutrophil. There are the three nucleus, three lobed nucleus, okay? These granulated structures are eosinophil. Now see this elongated structure here, the twisted one. This is called Kurzman spiral. Kurzman spiral looks like this. There are a lot of eosinophil present in the sputum, and these are called Charcot-Leyden crystals. Okay, Charcot-Leyden crystals. So this is how sputum in case of bronchial asthma looks like. Now, if you analyze the airway with microscopy, or you can also say this as a morphology, the microscopic appearance of the airway, how it looks. Okay, now see here. There are lots of mucus plug present in the lumen. Okay, these are called Kurzman spirals. There is hypertrophy of mucus gland with hyperplasia of the goblet shell. As a result of this, there is a lot of mucus secretion. The airway is inflamed, especially with eosinophils, because this is allergic disease, so it is very easy for us to remember. The whole airway is edematous. That's why it is very narrow also. There is hypertrophy of bronchial wall smooth muscle. It will further make the airway narrow. There are thickened basement membrane. It will further make airway narrow. And all these features collectively is known as remodeling of the airway. This is excellent term in case of pathology, because the airway is remodeled in case of bronchial asthma patient. In comparison to the normal airway, it is absolutely different looking airway. So we call that remodeled airway. Now, if you see one picture, it will be very clear to you, okay? So I'm showing you right now to you. Now, see here. Let me explain with the help of pointer here. Okay. Now see this. This is a normal airway. Normal airway, on the surface of the epithelial cells, there is a mucus. These are the epithelial cell. Here is the basement membrane. Okay. This is called lamina propria. This is a part of mucosa, and this is a muscularis mucosa, isn't it? Now these are the glands. Okay. These are the glands, and here is the cartilage. Now, in comparison to the bronchial asthma airway, now see there. Number one, the whole thickness, okay, is increasing, and the lumen size will decrease. If the thickness of the wall increases, the lumen size will definitely decrease. I cannot show you the lumen here because the rounded structure is not shown, but you need to understand that. Okay. Now, why the lumen is narrower? There are so many reasons. One, look at the thickness of this mucus here. In this condition, just a very slight layer, but here very, very thick one. Number one. Number two, all these goblet cells and other cells are increasing in number, and they are overworking. Look at the basement membrane. It is also very thick. And look at the deposition of the inflammatory cells here. Look at this smooth muscle. This is also thick. And other glands are also hypertrophied and increase in number. So this is why the lumen in bronchial asthma, the lumen of the airway in bronchial asthma becomes very narrow. Okay. Now, before I go into the another topic, okay, let me simply tell you the management of bronchial asthma in few lines. But don't get scared. We never ask management in pathology viva exam. Okay, that is not the part of pathology. But I'm giving you that knowledge so that you can correlate the things and you can understand it easily. Now I can explain that management with the help of this diagram. Okay. Now, ipratropium bromide is a very important drug in the management of asthma because it can decrease the secretion in the airway and it will dilate the airway, both. But salbutamol cannot have that function. Salbutamol only dilate the airway, but it cannot decrease the secretion. Okay. Now, look at the role of inflammation here. These are all inflammatory cells, and these inflammatory cells are doing all the damage in bronchial asthma. If I give certain drug which can decrease this inflammation, it will do wonder for the patient, and that drug is corticosteroid. Corticosteroid. The most common route of corticosteroid in this case is inhalation. Inhalation. You give that corticosteroid, okay, through the inhalational route. It will not cause much side effect. At the same time, it will be much effective. Now, after we do bronchial asthma, let's move on to the bronchiectasis, another important topic in the respiratory system. Now, in the beginning, let's start with definition. Bronchiectasis means there is abnormal and permanent dilatation of bronchi and bronchioles, which is caused by destruction of the muscle and the supporting elastic tissue, and that is due to chronic necrotizing infection. Now let me make it simple for you. So what is bronchiectasis? Now just analyze the term here. Bronchi means bronchi and bronchioles. Ectasis means dilatation. So your definition is right here. Bronchi means bronchi or bronchioles. Ectasis means dilatation. So they are permanently dilated. Okay, they are abnormally and permanently dilated. Why? Because of chronic necrotizing infection, which is irreversibly damaging the supporting structure of the airway. And this supporting structure are muscle and the elastic tissue. Now, how this patient present? What happens? Okay, how this patient present to the hospital? Now, the patient will have cough. Okay, the cough is a serious type of cough with a lot of sputum production. This is one of the disorder of respiratory system where sputum production is massive, excessive, and this sputum is very foul smelling. Okay, so let me repeat again. Massive amount of sputum production. That sputum is purulent because repeated infection is going on. So it looks like a pus, very whitish or yellowish in nature, and it is very foul smelling. Now, whenever there is anaerobic infection in any area of our body, okay, the pus which is formed becomes very foul smelling. So whenever foul smelling sputum is produced by the patient, you immediately know this infection is caused by anaerobic organism. To be frankly speaking, both anaerobic organism and aerobic organism will cause the infection in bronchiectasis. Now, fever is very common because there is an infectious disease. Dyspnea is quite common. This is also a type of obstructive airway disease. But student may think differently because look at the definition here. The airways are dilated. Then how can it is a part of obstructive airway disease? The answer is very simple. That airway is filled with pus. The airway is filled with foul smelling purulent sputum. Okay. As a result of this is also considered as obstructive airway disease. And sometimes this patient develops hemoptysis. Now, can anyone tell me what is hemoptysis?
Sir, blood in sputum.
Blood in sputum.
Very good. Okay, I got your answer. That is absolutely correct. When somebody coughs out blood in the sputum, okay, that is called hemoptysis. So hemoptysis may be a part of bronchiectasis, but it is seen in so many other conditions as well. Now let's see. Okay, let's see this picture. This is a schematic diagram, but this is a very effective one to explain what happens in bronchiectasis. Now this is the trachea. Okay, trachea is dividing into two bronchi. This is okay right and this is the left. Now see there, this bronchi, bronchus I should say, is divided into many other bronchi and bronchioles. Now look here, in this area, these bronchi and bronchioles are very wide and dilated. Okay, they are wide and dilated in a different shape. So according to the shape, the terms have been given. This is called varicose type. Okay, very tortuous type. Tortuous type is called varicose. This is cylindrical, just like a cylinder. Okay, uniformly dilated everywhere. This is fusiform. It's almost like a aneurysm. Okay, going towards one side. And this is saccular. So according to the shape, the types of bronchiectasis can be different. Okay. Now, what are the causes of bronchiectasis? You must be eager to know what are the causes of bronchiectasis. Now, remember one important point which I told you in the definition. This disease is mainly caused by chronic necrotizing infection. Chronic necrotizing infection. And there are so many risk factors for infection. One of the common risk factors for infection is bronchial obstruction, either by foreign body, either by mucus plug, or by tumor. Now, why bronchial obstruction can lead to infection? The answer is very easy, because our airway constantly secretes mucus. That mucus has to be coughed out. Okay, it has to be coughed out. If that cannot happen because of bronchial obstruction, the infection will automatically occur. And if it becomes chronic, that infection can lead to bronchiectasis. Another important cause is necrotizing pneumonia, means very severe type of pneumonia. I can take one important example here, that is staphylococcal pneumonia. This is one of the most severe type of pneumonia which occur, which is a necrotizing type. Cystic fibrosis is a genetic disease. Okay, it's a genetic disease where there is excessive secretion of sodium and chloride in the sweat. Rather than sodium, we measure chloride in the sweat to diagnose cystic fibrosis. This is a disease which affects exocrine gland. Exo. Now, exocrine and endocrine gland, I'm sure you have studied before, right?
Yes, sir.
What is
Yes, sir.
exocrine gland? Can anyone tell me what is exocrine gland? Anyone? What is exocrine gland?
Ductless duct. Yeah.
So they are
Okay.
gland that secrete material onto some surface. Generally, the skin, the gastrointestinal tract, or respiratory.
Ductless.
Okay, so I'm getting different answers here. Okay, so let me organize that answer. Very good. Okay, whenever I ask the questions to you, any student can answer. Just unmute yourself and answer. Okay, and immediately mute yourself. Otherwise, it will be very disturbing for all of us. Now, exocrine gland means the gland which has got duct. They secrete the substance into the duct. These are called exocrine gland. And sometimes they can directly secrete the things outside, but endocrine glands, they secrete their secretion into blood directly. So that is the big difference. So this cystic fibrosis mainly affects exocrine gland. Now, the common organ which are affected by cystic fibrosis are lung and pancreas. Even liver is affected. So remember these three organs: lung, pancreas, and liver. And for the diagnosis, sweat glands are important. Okay. Now, because of thick type of secretion in cystic fibrosis, bronchiectasis is very common to occur. Now, another one. Okay, so let's resume our class. We're talking about bronchiectasis and the causes. Now, the most important cause out of these all are different types of bronchial obstruction, maybe caused by foreign body, maybe by mucus plug, or by tumor. One of the important tumor here may be bronchogenic carcinoma. Okay, that is the commonest lung cancer. Now, another one is a necrotizing pneumonia, which are very severe type of pneumonia, and one example is staphylococcal pneumonia, okay, which is considered a very serious one. Cystic fibrosis is a genetic disease which can lead to bronchiectasis, and this cystic fibrosis mainly affect exocrine gland. Now, there are a lot of exocrine gland on the wall of the airway. So airway or lung can be badly affected by cystic fibrosis. The main problem in cystic fibrosis is the secretion which comes out from this gland will be very thick. As a result of this, there will be obstruction. That obstruction will attract infection, and that infection becomes chronic, which leads to bronchiectasis. Now, other organs which are affected by cystic fibrosis are pancreas and liver. Okay, in pancreas, they can damage the exocrine part of the pancreas. So there are lots of enzymes which comes out from the exocrine pancreas, which are absolutely necessary for digestion and absorption of the food. Now, if that cannot happen, then the person will have malabsorption. So cystic fibrosis patient have severe malabsorption and diarrhea. In liver, cystic fibrosis can lead to cirrhosis of the liver. Okay. Now let's move on. Another important question which may come from bronchiectasis topic is Carter-Jenner syndrome. This Carter-Jenner syndrome is one of the cause of bronchiectasis. Now, let me discuss this in a bit detail because you guys want to know a bit more, isn't it? All are looking interested to learn. So let me explain a little bit more in each of these interesting points. Carter-Jenner syndrome is a type of primary ciliary dyskinesia. Okay, primary ciliary dyskinesia. Now, what does that mean? The cilia which are present in the airway do not function properly, and the reason is written here. They are immotile due to the defect of dynein arm. This dynein arm is one of the structure of the cilia which is defective here. As a result of that, those cilia will become immotile. Not only the cilia, okay, the flagella which is present in some of the organs are also defective here. Okay, but Carter-Jenner syndrome is primary ciliary dyskinesia with situs inversus. Now look at this term here, situs inversus. Now, can anyone tell me what is situs inversus?
Sir, all the abdominal organ are placed in opposite place.
But the major visceral organs are removed from their normal position.
Okay, yeah, you're absolutely correct. Okay, so situs inversus means the visceral organ are present on the opposite side. For example, liver is normally present on the right side and spleen is normally present on the left side, but in situs inversus it's exactly opposite. Even heart is present on the right side in this type of situation. So bronchiectasis, sinusitis and situs inversus, if these three things are combined together, we call it Carter-Jenner syndrome. It's a type of primary ciliary dyskinesia and it runs in the family because of autosomal recessive inheritance. So autosomal recessive means there is 25% chance of recurring in every pregnancy. Okay, this is the meaning. Let me erase it and then I'll move on to the next slide. Now see here. So what are the gross and microscopic appearance or features in bronchiectasis? Let's talk about this. This is an important part of pathology lecture. So when I look at the lung grossly, okay, there are dilated bronchi and bronchioles which are extending out to the pleura. Now let me show you here. See this. These are the dilated bronchi. See here. These bronchi are dilated and they are filled with pus. This white material present inside the bronchus are pus. Okay, almost the whole lung is affected here. And one of the very important feature is they have extended outwards towards the pleura. Okay, this is the important gross morphology of bronchiectasis. Now, regarding the microscopic appearance, if we take a biopsy from the lung and examine under the microscope, there are a lot of inflammatory cells seen. There may be the combination of acute as well as chronic inflammatory cells. It depends on the situation. Though bronchiectasis is a chronic disease, but on and off there are some exacerbation which happen, and exacerbations are usually acute. So during that time, the inflammatory cells are also neutrophils. In other setting, chronic inflammatory cells will be there. Complications of bronchiectasis would be abscess formation. For example, in this area, okay, I can see a bit of complicated situation. So this can easily turn into the abscess. Another area is here. It can easily turn into lung abscess. Lung abscess is a localized collection of pus inside the lung. Now, this infected material can easily move on to the other organ, which is known as septic emboli, and it can cause infection in that particular organ. This is a very important complication. Third one, cor pulmonale. Okay, cor pulmonale means because of the chronic parenchymal lung disease, there is failure of the right side of the heart, and the mechanism here is chronic hypoxia. Once again, because of this affection of the lung, there will be hypoxia. If this hypoxia is chronic, there will be pulmonary vasoconstriction. Now pulmonary hypertension occurs, and after pulmonary hypertension, the right ventricle will hypertrophy in the beginning and dilate later on. This is known as cor pulmonale. Amyloidosis is a very common complication, not only of bronchiectasis, but in so many other infective and inflammatory conditions. This means the liver is trying to form one abnormal protein which is called amyloid, and this amyloid protein can be deposited in different organs and it can cause the damage. Okay, so these are some of the important points in case of bronchiectasis. Now, before I move on to the pneumonia, what treatment may be necessary in bronchiectasis? Who can tell me? What treatment should I do?
Sir. Antibiotics.
Good. One is antibiotic. What is another one? After antibiotic, what is the next?
Metronidazole, sir.
Okay. Now,
alpha 1 agonist.
Okay. Now listen. This very easy answer. Okay. I don't want to go into the detail, but just want to give you the concept here. Now, this is a very badly affected lung. So if only one area of the lung is affected, after treating with antibiotic, if this patient doesn't get better, I can remove that area of the lung, which is called lobectomy. So this lobectomy is very commonly done in case of bronchiectasis. But if whole lung is affected, I cannot remove it. Okay, I cannot remove the whole lung. Okay, it can be removed, but in a very, very serious condition. Now another one, I have to give something which will help this pus to drain out. Okay, I can give some medicine which will liquefy the sputum. Acetylcysteine is one of the drug which will do that job. And another is chest physiotherapy. So we can do certain physiotherapy so that this infected material from the bronchus would come out. So these are the different concepts of treatment in case of bronchiectasis. Nice. Now let's go to pneumonia. So I've labeled this as a pneumonia syndrome because multiple different types of pneumonia are combined here. Okay, let's start with the definition. So please, all of you can see here what is pneumonia. See here. So pneumonia can be very broadly defined as any infection in the lung. Now this is a very broad type of definition, very vague definition actually. What that infection is doing to the lung, you can always add it there. So some of the textbook mention this is an infection of the lung parenchyma which leads to consolidation in the lung. Now consolidation means solidification of the lung. Okay, so when I move further into this topic, that term will come so many times. So let me repeat again. Any infection of the parenchyma of the lung which results in consolidation is called pneumonia. Now, what are the types of pneumonia? So let's classify it first. Now, first is community acquired pneumonia. Okay, community acquired pneumonia. Sorry, let me erase it first. Okay, it caused a little bit confusion here. Fine. So community acquired pneumonia is the first one, and there are multiple community acquired bacteria which can cause a community acquired pneumonia. Look at the names here: Streptococcus pneumoniae, which is also known as pneumococci, Haemophilus influenza type B, Moraxella catarrhalis, Staphylococcus aureus, Legionella pneumophila, and certain Enterobacteriaceae like Klebsiella and even Pseudomonas. Now among them, the top four are very common: pneumococci, Haemophilus influenza, Moraxella catarrhalis, and Staphylococcus aureus. These are called community acquired acute pneumonia. Now the second type can be community acquired atypical pneumonia. Now these atypical pneumonia are a bit different from the typical bacterial pneumonia. So we'll talk about that. This is a major part of today's discussion. Now let's talk about the organism here. Mycoplasma pneumoniae, chlamydia species like Chlamydia pneumoniae, Chlamydia psittaci, this is pronounced as psittaci, and Chlamydia trachomatis. These are different species in chlamydia. All of them can lead to atypical pneumonia, but more common are Chlamydia pneumoniae and Chlamydia trachomatis. Coxiella burnetii, causes Q fever. Coxiella burnetii is a type of bacteria which causes Q fever. Not very common at all. You don't need to know much about it. Just name is enough. And different viruses. Look at the name: respiratory syncytial virus, RSV, parainfluenza virus, influenza virus, which are influenza A and B, and adenovirus. You can add a lot of other viruses here. These days, the virus which is causing trouble to all of us, the coronavirus, it can be very easily written here. Rhinovirus. So many viruses are there which can cause community acquired atypical pneumonia. Now the third classification is nosocomial pneumonia. Nosocomial means hospital acquired. Now the patient was not having pneumonia at the time of hospital admission, but somehow this patient develops pneumonia inside the hospital. This is called nosocomial pneumonia, and usually very virulent or very complicated type of organisms are responsible, like gram-negative rod or bacteria, which belongs to Enterobacteriaceae family, like Klebsiella, E. coli, Pseudomonas, Serratia. Many different examples can be given here. And never forget about Staphylococcus aureus, which is MRSA or MRSA positive. That means methicillin resistant Staphylococcus aureus. This is a highly dangerous type of organism which can cause hospital acquired pneumonia. Now one small question to you guys: why these hospital acquired pneumonia are very serious in comparison to the other?
Because organisms are very resistant to many drugs, that's why it's very complicated.
Very good. I got the answer from Irfan. Wonderful. Because those organisms are multi-drug resistant. Now we have already tried multiple antibiotics inside the hospital. So if we are infected with this type of bacteria, the antibiotic which we have given may not work against them. And by the time we realize that, it may be too late. So that's why these organisms are considered as highly lethal. The common examples are Pseudomonas, Klebsiella, E. coli, as well as Staphylococcus aureus, which is MRSA positive. Now another type of pneumonia is aspiration pneumonia. Now aspiration means something is trickling down into the airway, and usually it will happen from our oral cavity, pharynx or GI tract. Oral cavity, pharynx or GI tract. And usually the aspiration pneumonia is caused by mixture of the organism. Usually they are anaerobe and aerobe, which are mixed together. So remember this, this is considered a very serious type of pneumonia. So some of the anaerobic oral flora which are written here are bacteroids, Prevotella and Fusobacterium, as well as Peptostreptococci. These are the examples of anaerobes. They may be mixed with aerobic bacteria like pneumococci. This Streptococcus pneumoniae is pneumococci, Staphylococcus aureus, Haemophilus influenza, and Pseudomonas aeruginosa. They are aerobic. So this may be the mixture of the infection. Now some of the students were mentioning about the use of metronidazole in the beginning. Now this infection definitely needs metronidazole to cover this anaerobe, and we need to combine metronidazole with either penicillin or cephalosporin to cover other aerobe as well. Now another classification is chronic pneumonia. Now look at the organism there, nocardia and actinomyces. Okay, they are bacteria, and these organism which we have listed as a granulomatous pneumonia. Okay, some are fungi and some are bacteria. Now this Mycobacterium tuberculosis and atypical mycobacteria are the chronic type of bacteria which can cause tuberculosis, and okay, this the atypical mycobacteria, probably you have I'm not sure whether you have studied this before or not, like Mycobacteria kansasi, okay, Mycobacterium scrofulaceum, Mycobacterium marinum, Mycobacterium avium intracellulare. These are the different examples. These are called atypical mycobacteria, and the name of the disease is also same. We call that atypical mycobacterial infection. So these are granulomatous diseases. Now, these three names are fungi: Histoplasma capsulatum, Coccidioides amitis, and Blastomyces dermatidis. All of these are called dimorphic fungi. This is one of the special classification under fungus, okay, which are called dimorphic fungi. So all of them can lead to chronic pneumonia. Now, another type of pneumonia can be necrotizing pneumonia and lung abscess. Now, these are very severe type of pneumonia. Necrotizing means the parenchymatous part of the lung is getting dead. Okay, it is necrose. So it has to be severe pneumonia. So anaerobic bacteria are very common here. Sometimes they are mixed with aerobic as well. Staphylococcus aureus, I have already given example to you before. This is a very virulent organism. Klebsiella, Pseudomonas also I want to add here, and even Streptococcus pyogenes, which is also known as group A beta hemolytic streptococci. It is also a necrotizing type of pneumonia. And another type is pneumonia in the immunocompromised host. Now, if somebody is immunocompromised, then they cannot fight against the infection. So any type of infection can occur in that individual. So more common one are written here, like cytomegalovirus can cause the pneumonia. Pneumocystis carinii can cause pneumonia, especially in AIDS patient, because AIDS is one of the perfect example of immunocompromised situation. So those people will have pneumocystis carinii pneumonia. These days, the name of the pneumocystis carinii has been changed. We call that pneumocystis girovesi. Okay, pneumocystis girovesi. Let me write that spelling for you. The pneumocystis is same one. Okay, so we write it pneumocystis girovesi. This is the preferred term these days. Now, another organism can be Mycobacterium avium intracellulare, which is considered as atypical mycobacteria. This is a fungus, okay, which is aspergillosis, and candidiasis is also a type of fungi. So these fungi or fungus infection are also not common in the person who have got good immunity. They are very common if immunity is poor. Okay. Now, after doing the classification, let's talk about the most important part out of these all, which is a bacterial pneumonia. Okay, if any question comes from this topic, it will be asked from here. Now, bacterial pneumonia is acute inflammation and consolidation of the lung due to a bacterial agent. Very easy definition. Acute inflammation and consolidation. Consolidation means solidification. The lung normally is a spongy organ. Okay, it is not solid. It is a spongy organ. It is filled with air. But after pneumonia, that spongy organ will change into a solid organ. That's why it is known as solidification or consolidation. This is the very important concept. Now, what are the clinical signs and symptoms of pneumonia? Just have a look there. This patient is having high-grade fever with chills and rigor. Now, though rigor is not written here, rigor can be there. Now, what is chills and what is rigor?
Sir, chill mean cold sensation.
Okay, and what is rigor? What is rigor?
Contraction of muscles.
Stiffness
Like-
of muscles.
Okay, very
Stiffening, hardening.
Very good. Good. I already got the answer. You're right, actually. Okay, you're absolutely right. So
Rigor mortis.
let me explain this again. Chills means feeling cold. Is absolutely correct. I think Zulfikar has answered that. He is right. Chills means feeling cold.
Yes.
Now
Sir.
rigor means remember there is shivering. Shivering is a very important term in rigor, and that shivering occurs because of muscle contraction. Now what is happening here? Okay. Now because of this chilling, feeling cold, okay, the body is accumulating heat inside, and during that process the skeletal muscle will contract, and that will generate a lot of heat. Means fever is going up and up, temperature is getting higher in the body. So these can be important feature of bacterial pneumonia. Along with fever and chills, the person will have cough and sputum production. Cough and sputum production. Now that sputum can be of different color. It can be frank pus. Okay, that pus may be whitish, or that pus may be yellow to green, or if that pus has blood, it may look rusty. So it can be anything. It depends on the situation. So in different textbook, it is very commonly written as a rusty sputum. Now rusty sputum means blood stained sputum. Tachypnea means faster breathing or faster respiratory rate. Normally, adult we have respiration of 16 to 18 per minute. 16 to 18 per minute. If somebody is breathing more than 18 per minute, it is called tachypnea. It's a very, very common feature of pneumonia. When they cough, they complain chest pain. Now that chest pain is very important feature in pneumonia. Remember, because that chest pain tells me exactly that site the disease is occurring. Means that part of the lung is affected by pneumonia. So this is called pleuritic chest pain. Usually parietal pleura should be inflamed, then only you have pleuritic chest pain. If visceral pleura is only involved, we don't feel any pain. Some other clinical features would be decreased breath sound, okay, and rales. Now decreased breath sound and rales are auscultatory finding. To know this, I need to auscultate the chest with stethoscope. Okay, ask the patient to take deep inspiration, and that affected area of the lung which have got consolidation, there is decreased breath sound, and this patient will have crackles or rales. Now crackles and rales are heard because of collection of fluid inside the alveoli. In pneumonia, in the early stages of pneumonia I am talking about, there is exudation. Now exudation is a type of fluid. So during that stage, rales or crackles are very commonly heard. And once the consolidation is complete, during percussion, now percussion, inspection, palpation, percussion and auscultation, these are the different clinical examination of the chest, which I will teach you during 5th and 6th semester when you move on to the clinical phase. But right now, you just understand, if I percuss the chest over the area where there is consolidation, there is dullness present. Okay. Now, what investigation you like to do to confirm your diagnosis, I only want to do two tests here, which are much more important than other. Those are complete blood count and chest X-ray. Complete blood count and chest X-ray. If I do complete blood count, there will be elevated WBC count because it is a bacterial infection, isn't it? So WBC count will be higher. And left shift. Now, can you tell me what do you mean by left shift in WBC count? Anyone? You have done hematology before, isn't it? You have completed it in third semester, I'm sure about it. What is left shift in WBC count?
Sir, there is
Sir,
high
when-
number of white blood cells. There is a high number of immature white blood cells.
Yes, Uzair, say it again.
Sir, left shift or blood shifter increase the number of immature
Sir, there is a high
leukocytes.
number of immature white blood.
Okay, Adnan, you have answered very correctly. Now, Uzair is also, doing the same later on. Now, listen it, okay? Most of the students, I cannot hear all the answers here because we cannot manage time if we do that. Left shift in case of WBC count means if there are presence of immature, okay, immature neutrophils, and those immature neutrophils are band cell, okay, and neutrophil with toxic granulation. During the peripheral smear, if I see band cell and neutrophil with toxic granulation, this is called left shift. That means this infection is very severe. And this pneumonia, bacterial pneumonia like lobar pneumonia or bronchopneumonia, they are serious disorders. Now, let's talk about lobar pneumonia. Now, lobar means one whole lobe of the lung is affected. One whole lobe is consolidated. We have two lungs, right and left. In right lung, we have got 3 lobes, and in left lung, we have got 2 lobes. Now, out of those 3 lobes on the right lung, any of the lobe can be completely consolidated. This is called lobar pneumonia. So it is a very serious condition. The common bacteria which can cause lobar pneumonia are pneumococci. Okay, remember the name pneumococci or Streptococcus pneumoniae in almost 95% of the time, followed by Klebsiella. So pneumococci and Klebsiella, they are the usual pathogens for lobar pneumonia. Now we are moving on to a very important part of today's class. There are 4 classical phases in lobar pneumonia. The first phase, when the infection has just started, this is called phase of congestion or stage of congestion, you can say. Okay. Now in this stage of congestion, there is an increased edematous fluid which is collecting inside the alveoli. Okay, and there is increased blood flow as well. Now there are 2 terms which you can clearly see, hyperemia and congestion. Now hyperemia means increased arterial flow in that particular area, and congestion means decreased venous outflow from that area. They are not the same term, they've got slightly different meaning. Hyperemia is increased arterial flow in that area, and congestion means decreased venous outflow from that area. Now let's come back to the point. If both things are occurring together, then there will be collection of the blood in that area, isn't it? Which can easily give rise to edema. Now after congestion, we have got next stage which is called red hepatization. Now red hepatization is a very easy term to understand. Red means it looks red in color because of hemorrhage. Because of RBC, they look red. And hepatization means the lung is looking like liver. So because hepatic means liver, so hepatization means lung is converting like liver. Now let me remind you once again, lung is spongy organ and liver is solid organ. Now that spongy organ is getting solidified. This is called red hepatization. Along with RBC, a lot of neutrophils will go into that area. After that, the third stage is gray hepatization. After a few days, gray hepatization stage will be there, and during that time, degradation of red blood cells occur and the color will also change. And the last stage is resolution. If we give antibiotic for the treatment of pneumonia, then the patient will completely recover. All these hepatization will clear away and patient will get better. So these are 4 classical phases of lobar pneumonia. Okay. Now, what are the microscopic finding of pneumonia? What we see if we take a biopsy from the lung, we never do that. There is no need to do that, okay, for the diagnosis. But we are talking pathology. We want to know what is happening inside the lung. Okay, so let's talk about it now. There is collection of a lot of neutrophils inside the alveoli, and there is collection of fluid as well. This is an acute infection, so neutrophils play the big role. Okay, now let's see these pictures, which will make it very, very clear for you. Okay, the whole thing we have talked right till now will be repeated in these pictures. Now let me take the help of highlighter and then explain this. Now look at this A. This is a stage of congestion, and this lasts for 1 to 2 days, and this is a very initial phase. Okay, this is a gross morphology, and this is a microscopic feature. Though these are schematic diagram, but they are highly useful for us to understand. Now look at this area. It is enlarged and heavy. Okay, and there is already pleural inflammation has started. So at this stage itself, the patient will have chest pain. When they cough, they will have chest pain in this area. PMN means polymorphonuclear cells. This is another name for neutrophil, and lots of RBCs collect in this stage. Now the second stage is red hepatization. Now see, look at the color here. It look very red, okay, because of the RBC collection, and at the same time there are lots of neutrophils. So whole alveoli is replaced by neutrophil and RBC. There is no more ear now. It has already converted into solid structure, and this stage lasts for 2 to 4 days. Now the third one is gray hepatization. This is a late consolidation phase. It may last for 4 to 8 days. And look at the color now, okay? It become gray in color. The pleurisy means pleural inflammation is still there. It is still there, though it is in the slightly in the healing phase now. Okay, then those PMN cells or neutrophil cells are still there, but it is not as dense as the red hepatization stage. I can already see some gap here, means they are slowly going to resolve, and this is followed by resolution, which may complete in 1 week or 3 weeks. It depends on the treatment. If treatment is provided early, probably in 1. Okay, so let's start the class. So today I'm going to continue from the same slide where we left yesterday, that is lobar pneumonia. Now lobar pneumonia is mainly caused by Streptococcus pneumoniae or pneumococci and Klebsiella. Sometimes other organisms can also lead the condition, but these are much more common. And lobar pneumonia is mainly consolidation of the entire lobe. Okay, sometimes a main part of the lobe can also be consolidated, but we are talking about the usual or more common things, that is consolidation of entire lobe. In the right lung we have 3 lobes, on the left lung we have 2 lobes. So either one of these lobes or sometimes all of the lobe may be consolidated. Now there are 4 classical phases of lobar pneumonia. The first phase is congestion, second is red hepatization, third gray hepatization, fourth is resolution. And if we see a microscopic examination, there will be collection of a lot of neutrophils inside the alveoli. Now let's revise a little bit about this morphological feature. Now see here, so this lobe is going to be consolidated. This is a very early or first phase, so it is called stage of congestion. In this phase there is exudation occur, exudation, and inside that exudation a lot of neutrophils and RBC will be present. Second stage, red hepatization. It looks quite red and solid. Now it looks like liver, that's why the term hepatization. Now look at this, it explains why it looks solid. The third one, gray hepatization. Now it still looks solid, okay, color is gray, but inside the alveoli small spaces are already going to be created. That means it is going to resolute very soon. And the last is resolution. It takes 1 to 3 weeks for the resolution stage to be completed, and in that condition it is trying to go back to the normal lung. If we give antibiotic, all this process would be very faster. Now this is the microscopic examination of acute pneumonia. Now see here, okay, let me take the help of pointer here. Okay, see here. Now this is the wall of the alveoli, or septa, I can say, septa of the alveoli. Now this whole space inside the alveoli is filled with neutrophils. This dotted structure, this blue structure, what you can see are neutrophils. Okay, so this acute pneumonia has a lot of neutrophils inside the alveoli. Now how you know this is lung? You have to see very carefully. These are the alveolar septa, and this whole area is alveoli. Okay, it is fully filled with neutrophils. Now this is a schematic diagram which tells us how lobar pneumonia and bronchopneumonia looks like. See here, there is a patchy consolidation or patchy infiltration in one lobe or more lobes of a lung. This is bronchopneumonia, and this whole lobe is affected, which is lobar pneumonia. Okay, now let's talk something about a bronchopneumonia after this slide. Now see here, this is a real pathological specimen which you can see in the pathology lab. Now see this is okay, gray hepatization, the lower one. This is a real pathological specimen, not a schematic diagram. Okay, and this is bronchopneumonia. The whole area is not uniformly consolidated here. Rather than that, the patchy area is consolidated here. In this lung, this area is involved. You can see the color difference there. Okay, in this lobe, this area is involved. It has a density or color difference. So patchy involvement, bronchopneumonia, uniform involvement of the lobe, lobar pneumonia. This is the meaning. Okay, fine. Now what is bronchopneumonia? Let's talk a little bit about it. This is a scattered patchy consolidation which is centered around bronchioles. Bronchioles means they are smaller type of bronchi. This bronchopneumonia tends to be bilateral. They may involve both lung, multilobar, more lobe than one, and usually they are centered around the basilar area of the lobe. It affects very young, very old, and terminally ill patient. This is very young, very old, and terminally ill patient because all of them have one common characteristic feature, and that is immunosuppression. So because of immunosuppression, this bronchopneumonia is more common in them. Now the common organism which cause bronchopneumonia are Staphylococcus aureus, different type of streptococci, mainly Streptococcus pyogenesis rather than pneumococci, Haemophilus influenza, and Pseudomonas aeruginosa, which may be followed by so many other important bacteria. Okay, these are the main one, so they are highlighted. Regarding the microscopic feature, it is same between lobar pneumonia and bronchopneumonia because both are acute infection. So there are deposition of a lot of neutrophils, which is centered around the bronchioles and surrounding alveoli. Now there's a table which I picked from a textbook, so that it is a very informative one. All points may not be very important, so let me highlight which are the important points or must know points for you. Okay, let me underline them. Now here, definition is important, and by this time many students know lobar pneumonia, acute bacterial infection of a part of a lobe, of one or both lung or the entire lobe. So whole lobe is affected. Bronchopneumonia, acute bacterial infection of the terminal bronchiole, terminal bronchioles extending into the adjoining alveoli, bronchopneumonia. Now age group, it is more common in adults, and bronchopneumonia is common at extreme of age, means very young and very old. Very young means infantile age. Predisposing factor, this is mainly community acquired pneumonia, so it more often affects the healthy individual, whereas bronchopneumonia mainly occurs in some individual who already are ill, who already have pre-existing disease condition. This is important. Okay, some predisposing factor may be there. Regarding the common etiological agent, pneumococci and Klebsiella tops the list. Okay, maybe followed by some other, but here, okay, here Staphylococci, group A beta hemolytic streptococci, Pseudomonas and Haemophilus. These are the common organisms. Now all those morphological stages which we have just discussed, congestion in the beginning for 1 to 2 days, then okay, then gray hepatization and red hepatization and gray hepatization, which is also known as early or late consolidation, followed by resolution. This is very typical only of lobar pneumonia. In bronchopneumonia, all these features are not seen like this. Okay, it is not seen like this. It doesn't follow this particular pattern. Regarding the investigation, very easy, you have to do CBC. CBC means complete blood count. It will show neutrophilia. Blood culture should be done because it is bacterial infection, and X-ray is a must. X-ray shows consolidation of the entire lobe. Whereas bronchopneumonia, similar type of things, but X-ray shows focal opacity, which is present here and there. Prognosis is much better in lobar pneumonia and not that good in bronchopneumonia because the patient already have some other problem. And complications are also less common in lobar pneumonia, but they may occur. But in bronchopneumonia, they are more common. Okay, so like that, you have to revise it. So let me erase it first. Okay, so if I ask you in the exam, or if any other teacher asks you like this, now you can handle what is the differences between lobar pneumonia and bronchopneumonia. Now, how to diagnose pneumonia? We have repeatedly, discussed this. CBC, which shows neutrophilia. Okay, then blood culture can be done, chest X-ray can be done, and one more test is sputum, gram stain, and culture. If you do it nicely, then you can, isolate those organisms which are causing pneumonia. But if you do not eat well, then contamination or contaminant bacteria can grow, and they will still confuse us. So we should take this sputum and send to the lab very clearly. Now, what are the complications of typical or acute pneumonia. They may be fibrous scarring and pleural adhesion. Okay, fibrous scarring and pleural adhesion. So the pleura may get adhered on the surface of the lung. After that, there will be no pleural cavity left. Lung abscess, especially staphylococcal pneumonia and necrotizing type of pneumonia, may lead to lung abscess. Remember, abscess means it's a localized collection of the pus inside one area. Here we are talking about lung, so pus collection inside the lung. And sometimes it is covered by pyogenic membrane as well. Empyema means pus collection in the pleural cavity. Okay, pus collection in pleural cavity is called empyema. This is a very serious situation. And sepsis. Sepsis means presence of microorganisms in the blood. They are multiplying there, and signs and symptoms are also associated. So it is a serious situation than bacteremia. Bacteremia means only the presence of microorganism, but septicemia means they are actively multiplying along with sign and symptom. Now there is one part of pneumonia topic which is atypical pneumonia. Now the name itself suggests most of the clinical features which we see in typical bacterial pneumonia are not seen here. Okay, that is the meaning. Now let's start with what are the organisms which leads to atypical pneumonia. Now look at the list here. Mycoplasma pneumoniae. Okay, Mycoplasma pneumoniae. You can also add chlamydia here. Chlamydia pneumoniae, chlamydia trachomatis, and chlamydia psittaci. All of them can also lead to atypical pneumonia. Most of the viruses leads to atypical pneumonia, like influenza virus, parainfluenza virus, respiratory syncytial virus, adenovirus, cytomegalovirus, varicella virus. Okay, even all the other respiratory virus which we left here can still lead to atypical type of pneumonitis or pneumonia. Even coronavirus can be added here. Now there is one difference between bacterial pneumonia and viral or atypical pneumonia. Bacterial pneumonia causes infection inside the alveoli or at the end of terminal bronchiole, whereas these atypical organism, atypical means these are still bacteria. Remember, mycoplasma and chlamydia are still bacteria, but we don't call them typical bacteria. They are called atypical bacteria. That's why they are mentioned here. They mainly causes interstitial pneumonitis, interstitial space in between the alveoli. They start from there, and there is usually no consolidation when this disease is occurring. Now this atypical pneumonia is more common in children and adults. Okay, this may be common in young children and young adult. Now school going children are very commonly affected by atypical pneumonia, and even the young adults who are studying in the college or universities. Now what type of clinical features they have? They usually have a dry and very troublesome type of cough. They keep on coughing without producing any sputum, which is called dry cough. Okay, even if they produce sputum, it will be very, very scanty. Okay, so let me highlight these points for you because they are important one. See here, there's a dry and troublesome cough, very important feature, and no or very less mucoid sputum production. This is a very, very different from acute typical bacterial infection, in that there is cough with productive sputum, and the color of that sputum may be yellow, okay, it may be white, or sometimes it may be associated with hemoptysis. None of those features are present here. It is only dry cough. Another point, there is no or very low degree of fever. Actually there is no fever. So that's why most of these patients continue to do what they are doing before. For example, if a student was going to school, college or university before, he continued to go because he is not that sick. This is very, very important point. That's why many textbooks even write this type of pneumonia as walking pneumonia. Okay, this is also known as walking pneumonia. I'm going to write it here. Okay, walking pneumonia. So don't get confused. Sometimes they may ask and ask you about the question, can you tell some information about walking pneumonia? You don't need to be confused. They are asking the same atypical pneumonia here. Now, another important point here, patient looks not so sick from outside, which I just told you. And if we take X-ray, the X-ray looks much worse than the patient. The X-ray looks much worse than the patient. This is important point. Now, you will be surprised to see this X-ray and you look again at the patient. Patient doesn't look that sick. Patient is going to school. Patient is going to office. Okay. Patient is going to university. But can it be his X-ray? You'll ask question like this because X-ray looks much worse than the patient. This is a very, very typical feature. Now, related the microscopic examination, there is a deposition of lymphocyte and plasma cell within the alveolar septum. This is alveolar septum. This is not alveolar, inside the alveoli. This is outside the alveoli in the interstitial space. Now, some complications which can occur in atypical pneumonia are superimposed bacterial infection. Now, it will turn or change into typical bacterial pneumonia after that. And if that a child was suffering from viral illness like influenza or varicella, and to treat the fever, if the doctor or the parents give aspirin, then Rey syndrome can occur. So the two combinations should be necessary to have Rey syndrome. One is viral illness, another is use of aspirin. Now this Rey syndrome damages our liver, and that child can have hepatic encephalopathy after the damage of liver. This is a very serious condition. There is high mortality in case of Rey syndrome. So what is the lesson to be learned here? Don't give aspirin to a child who is having viral illness. We must give paracetamol, not aspirin. We can give ibuprofen, only paracetamol and ibuprofen for the treatment of fever. No aspirin at all, because you may badly damage the baby. Now, a small question I like to add here. Which antibiotic you use to treat this atypical pneumonia?
Sir, penicillin.
Moxifloxacin.
Okay. Yes.
Chloroquine, sirs. Chloroquine.
Okay. Now listen carefully. Maybe I'm not sure whether you have studied this in pharmacology or not, because this whole semester is gone. In third semester, I was not so sure about it. Okay. So listen carefully. The typical bacterial pneumonia, caused by pneumococci, and Haemophilus and similar sort of organism like Klebsiella, even Staphylococcus. We can use antibiotic which works against them, like penicillin, like cloxacillin, like flucloxacillin, combination of amoxicillin with clavulinic acid, and even macrolide, or even fluoroquinolones. All of those can be used there. But these are atypical organisms. Remember that even these bacteria are atypical. They don't have cell wall. So we cannot use penicillin group of antibiotic to treat them. Always remember this. No penicillin. No whole classification of penicillin cannot be used here. No amoxicillin, no ampicillin, no cloxacillin, no flucloxacillin. Nothing like that. So you have to choose macrolide groups of antibiotics. Now, which antibiotic comes under macrolide group? Yes?
Azithromycin,
Erythromycin.
Very good, very good. I already got the answer. Excellent. Very nice. It's erythromycin, azithromycin, clarithromycin, and roxithromycin. These are the names. So always answer like that. Nice. Let's move on now. Now the last part of this topic is lung abscess, and after that I'll move on to the pulmonary tuberculosis. Now, what is lung abscess? Let's talk about etiology, clinical feature, and some of the complication. Now, lung abscess is localized collection of pus and necrotic pulmonary parenchyma. You can simply say pus, okay, but along with pus there is necrotic pulmonary parenchyma as well inside one part of the lung. Okay, it is a localized collection of pus, and many of the time it is surrounded by a pyogenic membrane. It is surrounded by a pyogenic membrane. So you can mention it there if you want, but even if you do not write, it's fine. Localized collection of pus in one particular area of the lung is called lung abscess. Now, what are the common causes or etiology? Okay, these are aspiration. Now, aspiration is the most common cause of lung abscess. Because of aspiration, there tends to be infection, and the aspiration mainly occurs in the right lung and towards the lower lobe of the right lung. And in case of aspiration, we have mixed type of bacteria because it mainly goes from the oral cavity, and in oral cavity we have a lot of anaerobe and combination of aerobe. So usually it's a mixed flora. That's why when we are using antibiotic, we need to cover this anaerobe as well. And two important antibiotics are there to cover the anaerobic infection. These are metronidazole and clindamycin. Metronidazole and clindamycin, remember that. Now, they usually suffer or occur from these very typical complicated type of pneumonia like Staphylococcus aureus and Klebsiella pneumonia, which are considered more complicated type of pneumonia than other. Okay, and they can quickly worsen into lung abscess. Post-obstructive lung abscess can occur. For example, if one a small bronchi or bronchioles is completely obstructed by tumor, okay, by foreign body, okay, or even by the dry or hard type of mucus, then also because of the repeated infection, lung abscess can happen. And another cause is septic emboli. Okay, inside the lung, the organism have come from some other area, that is called septic emboli, and it may cause repeated infection and lead to abscess. Now the clinical features, because this is the infection, remember, so fever will be there. There will be chest pain, and there is cough with purulent sputum. Okay, cough with purulent sputum. These are important one. And okay, cough with purulent sputum. And regarding the complication, it may leak into the outer pleural cavity. The pus may go into the outer pleural cavity, which is called empyema. There may be hemorrhage occurring inside the lung as one of the complications. So the person may have hemoptysis, and this is a chronic infectious disease. So amyloidosis is a non-complication in case of lung abscess. Now, how we are going to treat lung abscess? What is the treatment? Anyone?
So drainage completely. Antibiotic.
Very good. You already have got the concept. Excellent. Wherever abscess occurs, wherever in the body, okay, we don't care what area is that, you need to go for incision and drainage. Incision and drainage. Now it is inside the lung, so probably a surgery has to be done to drain it, followed by broad spectrum antibiotic, which will cover all type of organisms. Now at the end, these are the questions. Okay, let's not discuss this in the class because it will take a lot of time, and you have already done this question and submitted to me. Okay, so you can handle this on your own way. Okay, so with this, let me start another part of today's class. Okay, another part of today's class, that is pulmonary tuberculosis and neoplasia of the lung. Now see here, Now, pulmonary TB. Now, what is the causative agent of pulmonary tuberculosis? That's the first question.
Mycobacterium tuberculosis.
Okay, Mycobacterium tuberculosis. Very good. But in different book, okay, some other organisms are also mentioned. But at this level, if you tell me Mycobacterium tuberculosis, you will get excellent marks because that is the most common organism. Mycobacterium bovis can also cause tuberculosis, okay, and Mycobacterium africanum can also lead to tuberculosis, but those are rare type of organism. Now see here. So what is pulmonary tuberculosis? Let's discuss in a nice way. This is a chronic infective disease which is caused by Mycobacterium tuberculosis and Mycobacterium bovis. So this is a chronic disease. When we hear the term tuberculosis, it is always chronic. Now, how you know this is a chronic disease? I'll give you one example here. If a patient comes to the hospital and you take the history, patient says, doctor, I have cough for only 1 week. That is not chronic. I don't even consider TB during that time. But if the same patient say, I am coughing for more than 2 weeks now, it almost reaches 3 weeks now. Now I can consider, yes, this can be tuberculosis. So acute type of cough is not the presentation of tuberculosis. We always think bacterial infection at that time. Okay, we treat that with antibiotic. If patient doesn't get better, we follow up that patient, and if the patient continue to have similar type of symptom and sign, then we think about tuberculosis. Okay, this is very, very important point. Now, another question, how this tubercle bacilli or Mycobacterium tuberculosis enter into the lung? Now, this is because of cough and aerosolized bacilli. Now, let me explain and make it easy for you. For example, there is a patient of TB, pulmonary TB, who is coughing without using any mask. Okay, the person is coughing happily, and there are lots of people surrounding that patient. Now, when he cough, thousands of the droplets, okay, are released on the environment, and the person who are healthy, when they are breathing, those droplets, okay, or they are also known as aerosolized bacilli, can easily enter into our airway. This is the way tuberculosis is transmitted from one person to the other. Never forget this. Any type of tuberculosis, any, okay, this is the mode of transmission. Always tubercle bacilli enter into the body through lung. There are few exceptions, like Mycobacterium bovis can enter the GI tract through the ingestion of milk. But how common is that, isn't it? We always talk common things first in medicine. So more than 99% of the time, the entry route is airway and through the lung. And that is because of the person who has got positive sputum, means bacteria are present there. Now, clinical presentation of tuberculosis. Now, here, the patient is having fever. Now, this fever is low grade fever, okay, low grade fever and night sweat. Now, this fever is low grade, it is never high grade. In TB, high grade fever is not common, and evening or night sweat. Anorexia and weight loss, very, very common feature. Because of the chronic illness or chronic disease, the person doesn't want to eat and there is severe loss of weight. You have to take this history. How was your weight before? Okay, did you take weight any time in your life? And if the person say, no, I don't know my weight, I cannot tell you, doctor, then you can ask the family member, what do you think? How much weight he has lost? Then they will tell you. So if they say he has lost significant amount of weight, okay, it helps in the diagnosis. Now, cough is very common. Cough. Along with cough, there is chest pain in case of tuberculosis. Okay, and very important feature, hemoptysis is also occurring. Okay, yesterday students nicely told what is hemoptysis. Okay, so everybody know Hemoptysis means coughing out blood. Coughing out blood in the sputum, that is hemoptysis. So the typical clinical feature would be, let me repeat once again, low grade fever and night sweat, anorexia and weight loss, significant weight loss, cough with chest pain, and hemoptysis. Very, very common. Now, the common age group who develop tuberculosis are younger people. And these days, because of HIV and AIDS, a lot of people are getting tuberculosis all over the world. Okay, earlier from the developed country, tuberculosis was almost, very few cases of tuberculosis were present there. But these days, because of the emergence of HIV and AIDS, more and more people are getting tuberculosis. So we need to know in detail about this. Now, if you take biopsy from that infected area, okay, what will you see in a case of tuberculosis? Okay, it is very clearly written here. This is caseating granuloma. Caseating granuloma with acid-fast bacilli. Caseating granuloma with acid-fast bacilli. Now, let me explain to you what do you mean by granuloma. Now, granuloma means it is a millimeter size nodules which is composed of activated macrophages, okay, activated macrophages. Then, okay, some of those activated macrophages are fused with each other and form giant shell, and in this condition we call it Langhans giant shell. Langhans giant shell. So Langhans giant shell, activated macrophages which are called epithelioid shell because they look like a squamous looking shell, followed by plasma cell, lymphocytes, and fibroblast. So this whole combination is called granuloma. Now look at this picture. Okay, we have less than 1 minute time, so let me quickly do it. Okay, so this whole area is called granuloma. Okay, this is a magnified view. This is a caseous necrosis at the center. Okay, and these are different areas of granuloma. Granuloma are the hallmarks of tuberculosis. Whichever TB you are talking about right now, pulmonary TB is our topic. But if you talk about meningeal tuberculosis, bone and joint tuberculosis, GI tract tuberculosis, renal tuberculosis, whatever, if you take biopsy, the only finding is caseation granuloma, and that will give us the diagnosis. Okay. Now, fine. So we are talking about pulmonary tuberculosis, and before the break I talked about what are the clinical presentation of pulmonary TB. They are mainly fever and night sweat, anorexia and weight loss. This weight loss is a significant one. If a patient remember their weight, it is easy for us to calculate. Otherwise we need to ask to the family members or friends. Now, small clinical knowledge I want to give to you here. Sometimes if the patient knows their weight, then we can say in the last 6 months how much weight you have lost. So if they say certain weight, certain kg of weight, we can calculate the percentage. If they have lost more than 10% weight in the last 6 months, this is called significant weight loss. More than 10% weight loss in last 6 months, this is called significant weight loss. And tuberculosis is one of the disease where significant weight loss occurs. Now let's move on. Now pulmonary tuberculosis are mainly divided into primary and secondary pulmonary tuberculosis. So let's talk one after other. Now, primary pulmonary tuberculosis occurs in children. They mainly occurs in children, and they occurs on initial exposure. Okay, adult usually get secondary pulmonary tuberculosis either by reactivation or reinfection, but children, they get primary pulmonary tuberculosis. There are hallmarks of primary pulmonary tuberculosis, and they are known as gone focus or gone complex. Now, gone focus is subpleural caseous granuloma above or below the interlobar fissure. So you can simply say subpleural KGS granuloma inside the lung. This is called gone focus. And what about gone complex now? Complex means there must be some other features together, and that is, along with gone focus, if we have hilar lymphadenopathy, okay, hilar lymphadenopathy, then it is known as gone complex. Now, some of the textbook also mention there is lymphangitis in between. So from gone focus through the lymphatic channel, Mycobacterium tuberculosis reaches the hilar lymph node. So those lymphangitis or inflammation of lymphatic channel is also a part of gone complex. But even if you don't say that, we'll understand, because how they reach that lymph node through those lymphatic channel, so it is understandable. So the important point here is gone complex. Remember the term, which is the hallmark of primary pulmonary tuberculosis. Now, most of these lesions of primary pulmonary tuberculosis, they undergo fibrosis and calcification. Only 5% of them will remain active or remain latent. Latent means they may remain hidden inside the lung. And later on, when favorable situation comes, they may reactivate again and can cause the disease. Now, this is called secondary pulmonary tuberculosis, which may usually happen in adult. Now, look at this picture here. Okay. Now, see there. This is trachea. Okay. Bronchi, right bronchus and left bronchus, and divided into other bronchi. Now look at this. These are the hilar lymphadenopathy, enlarged lymph node. Here is Ghon's focus. Okay, this is subpleural granuloma, and from there, along with lymphatics, the Mycobacterium tuberculosis has reached the hilar lymph nodes. So you can say these three components are just the two component, that is lymphadenopathy with Ghon focus. This is called Ghon complex. This is a hallmark of primary pulmonary tuberculosis. Okay. Now, what is the pathogenesis of primary pulmonary tuberculosis? Okay, let's talk about it. What is really happening inside the lung? See here, in primary pulmonary tuberculosis, okay, usually the incubation period is more than 3 weeks. Now what happens from the exposure till the development of sign and symptom, it may take more than 3 weeks. So the alveolar macrophage is already present inside the alveoli. Now when Mycobacterium tuberculosis reaches there through the airway, and how it reaches there through the airway? Because of exposure to the person who is coughing, okay, freely in the environment, and if some healthy person will inhale that aerosolized bacilli or that infected droplet, then it will easily reach the lung. Now what happens inside the lung? That's what I am talking right now. Okay, now see here, let me highlight and talk about this. So alveolar macrophage, okay, has got two important functions. We all know that. One, it acts like a antigen presenting cell, and another, it can do phagocytosis. So what it will do first, it will phagocytose that Mycobacterium tuberculosis, process it inside, and then present a small peptide with the help of MHC class 2, okay, MHC class 2 to T cell. See there, this is Mycobacterium tubercular antigen. Okay, this is the green small piece. Class 2 MHC, major histocompatibility complex, MHC class 2. Okay, because this is an antigen presenting cell, so it is presenting antigen to the T cell. Okay, 1 second. I have to accept the students here. Okay, fine. Now what happens? Now see here. Now this T cell will become active. Okay, T cell will become activated and it will differentiate into Th1 helper cell. Okay. Now this cell will release interferon gamma, very important cytokine, interferon gamma, which will stimulate this alveolar macrophage, which was not very active before. So after the stimulation by interferon gamma, this macrophage, okay, will become active, and we call this epithelioid cell. Now epithelioid cell are activated macrophages, and they are activated by interferon gamma, which is released by T helper cell 1. Now this activated macrophages have more killing ability. They can kill the Mycobacterium tuberculosis better than before. So see that they have bactericidal activity. Okay, these are all nitric oxide and free radicals. With the help of these, they can kill that. Now there is one important point written, which is called tuberculin positivity. Okay, tuberculin positivity. Now tuberculin test or Mantoux test or PPD test we do to know whether this person is infected with tubercle bacilli or not. And when this stage is already reached during pathogenesis, tuberculin positivity will be there. That means the microorganism is already entered the lung. It has been processed by alveolar macrophages and presented to the T cell. Now T cells are already activated, and only during this stage tuberculin positivity will be there, even if you do Mantoux test. And after this also, the whole of the duration, tuberculin positivity will be there. Okay. Now this macrophage is already becoming very active and powerful, so it can, okay, it can kill the organism well, or if it cannot kill, it will contain the organism in that particular area, and containment of the organism in a particular area is done by granuloma formation. This is the purpose of formation of granuloma. If somebody asks you why granuloma is formed, you can say this is containment of the mycobacterium into that particular area. If it cannot kill properly, it will not allow it to escape from that area. That is called containment, and that is the function of granuloma. So at the center there is caseous necrosis, followed by epithelioid cells. These have altered and more powerful sort of macrophages. Okay, they are again surrounded by plasma cell, other T cells, and finally by fibroblast. So this is called epithelioid granuloma or caseous granuloma in case of tuberculosis. So if you understand like this, this is the very in the short form pathogenesis of pulmonary tuberculosis. Now what will happen to primary pulmonary tuberculosis, or in other words, what is the fate? What is the fate of primary pulmonary tuberculosis? Now there are 4 things which can happen. Now let me describe this with the help of this diagram, and then we can go to this explanation a little bit later. Now see here. Now this is gone focus, which is the hallmark of primary pulmonary tuberculosis. Okay, it can go towards the hilar lymph node to form gone complex. That is number 1. So this is called gone complex. Number 2, it can progress to the other area of the lung, which is known as progressive pulmonary tuberculosis. Progressive pulmonary tuberculosis. If the immunity of that child is not good, this can happen. Number 3, it can go towards the pleural cavity. Now, this is pleural cavity, which is outside. So when it reaches to the pleural cavity, it can lead to pleural effusion. It can lead to pleural inflammation in the beginning and then pleural effusion. This is the 3rd fate. And the last one, it can enter into the blood. Okay, it can enter into the blood, and through the blood it can go outside the lung. It can go anywhere. It can go to the pericardial cavity. Okay, it can go towards the brain. It can go to the bone. It can go to the kidney. It can go to the GI tract. It can go to other area. And this is how extra pulmonary tuberculosis can occur. So these are the 4 fates of a primary pulmonary tuberculosis. Now, what are the sequelae of primary complex? What can happen to that primary complex? Okay, that is called sequelae. Now, see there, it is very nicely written. A is healing. It can heal completely, and after healing, okay, it may calcify, or there may be extensive fibrosis. Fibrosis and calcification. The calcification is written here, fibrosis here. So, okay, it has healed. Now, there are no live organism probably here. Now, B, there is a progressive primary. Okay. Now, because of the lack of immunity, it is progressing inside the lung. See there, it is progressing inside the lung. Now, it has affected many different parts of the lung. Third one is a miliary spread. Okay, this is a miliary mottling. We say very small size granuloma are scattered on both lung or even on other organ. This is called miliary tuberculosis or miliary spread. This is considered very severe form of tuberculosis. And D, it's a reactivation of the primary. That means these are probably lying in the dormant stage or hidden stage or latent stage. Later on, because of decreased immunity, they can reactivate again. So all of these are sequelae of primary complex, okay, or gone complex. Now, all of you, please focus it here. This is the histopathology of tuberculosis. Histopathology of tuberculosis. That means this is caseous granuloma. Caseous granuloma. Now, this is caseous necrosis. This is a very magnified view. This is caseous necrosis here. You can see pink substance. Okay, Langhans giant cell, relatively big looking cell here. Okay, these all are epithelioid granuloma. This is surrounded by activated macrophages or epithelioid cells. So because this area is magnified, so we cannot see all the component. But at the center there is caseous necrosis. Now, after primary pulmonary TB, let's go and talk about some other types of tuberculosis. Now, secondary pulmonary TB occurs in the adult, and this occurs because of two mechanisms: reactivation or reinfection. Now, there is a slight difference between these terms, reactivation and reinfection. Let me highlight it. Reactivation or reinfection. Reactivation means the organism is already there in the hidden state or latent stage, and because of decreased immunity, that organism has become powerful again and can cause the disease. Reactivation. Reinfection means the new organism has entered the lung from outer environment and can cause the disease. This is reinfection. So there is a difference. And the lesion in the lung in case of secondary pulmonary TB is a cavitatory lesion. This is also known as fibrocavitary tuberculosis, because one particular area, usually towards the apex of the lung, is damaged, leading to cavity formation. This is a hallmark of secondary pulmonary tuberculosis, also known as post-primary pulmonary TB. Post-primary means after the primary. Okay, some of the textbook mention it like that as well. There is one important pathological term known as Simon focus. This Simon focus means granuloma is formed at the apex of the lung where there is high oxygen tension. Now, Mycobacterium tuberculosis is an aerobic bacilli. Okay, without oxygen it will die. It loves those areas which are rich in oxygen, and the apex of the lung are those areas which have high oxygen tension. So they multiply there, resulting in formation of granuloma, which is known as Simon focus. Please underline this. This is an important question in different exams. Now, what is progressive pulmonary tuberculosis? A progressive pulmonary tuberculosis can be anything out of these three, like cavitary tuberculosis, miliary pulmonary tuberculosis, and tuberculous bronchopneumonia. Out of them, the top two are more important. Cavitary tuberculosis, which is seen in secondary pulmonary TB, and miliary pulmonary TB means small miliary nodules are scattered throughout the lung. Now, these are called extra pulmonary TB, or because of systemic spread, okay, because of the systemic spread. So what are those? If it goes towards the brain and causes meninges inflammation, this is called tuberculous meningitis. Tuberculous meningitis. If it goes to the cervical lymph node, cervical means neck area, if lymph nodes of the neck are involved, we call that lymph node tuberculosis. Another term is also used, we call that scrofula. Scrofula is a lymph node tuberculosis in the neck region. Liver and spleen, kidneys, adrenals and ileum, any of these can be affected. So these are GI tract tuberculosis, renal tuberculosis, and even adrenal gland can be damaged by TB. Thoracolumbar vertebra can be badly damaged by TB, which we call as Pott's spine. Not only vertebra, even the joints can be affected, and the commonest of them is hip joint, followed by knee joint. Even the genital organs can be affected by extrapulmonary tuberculosis, like fallopian tube in female and epididymis in male. Okay, fallopian tube involvement is much more important than epididymis involvement, because if fallopian tubes are affected by tuberculosis, what will happen to that lady? Yes?
Pregnancy not occur.
No pregnancy. Infertility.
Okay, pregnancy doesn't occur, which is known as infertility. Very good. One more. I want one more answer.
Menstrual cycle may be affected, sir.
Ectopic pregnancy.
Okay, very good. It's ectopic pregnancy. Excellent. Ectopic pregnancy and infertility. These two are the most important problem if fallopian tube will have tuberculosis. Okay, very good. Now let's go to the another slide here. Now let's see some of the pictures. This is secondary pulmonary tuberculosis. You can see now. Let me highlight here once again. See this. Look at this apex part of the lung on both sides. There is a huge cavity there. Okay, you can see a cavity. This cavity, still some caseation necrosis material is left. This whole area. Later on, after this caseation necrosis material comes out through the sputum, this whole apex of the lung will turn into a big cavity. This is a feature of secondary pulmonary tuberculosis. And in this condition, there is miliary tuberculosis of the spleen. Look at this white dot-like structures. These are called miliary mottling. Okay, they are actually gray-white, but you can also say they look whitish structures, and this patient must be very seriously ill. Now, how we diagnose pulmonary tuberculosis? Okay, after studying all these things, now this question will be very easy for you to answer. Now, see here how we are going to diagnose. First of all, we have to do PPD or Mantoux skin test. And in case of tuberculosis, okay, usually, not always, okay, usually Mantoux test is strongly positive until and unless the immunity of this patient is very poor. We need cell-mediated immunity for Mantoux test become positive. If cell-mediated immunity itself is very low, then Mantoux test will not be positive even if that person is having tuberculosis. You need to understand that. Second one, positive sputum for acid-fast bacilli. Okay, you ask the patient to collect sputum and give to the lab. Okay, and during smear making and culture, we can see or we can grow these Mycobacterium tuberculosis. Now, which culture medium is used to grow Mycobacterium tuberculosis? What is the name of that culture media? Anyone? Maybe this topic was not taught to you, okay? So let me answer this question, because microbiology, is a subject of 4th semester and you are not in the university, so no problem. This is called LJ media. LJ media. So let me write this for you here. LJ media. Okay. Now the full form of LJ media is Lowinston Jensen media. Lowinston Jensen media is the one which we use for the culture of Mycobacterium tuberculosis, and it takes at least 6 weeks to grow that particular organism. So it is not like other ordinary bacteria. It takes a long time. Another important investigation you can do is complete hemogram. Okay, complete hemogram we can do. It is also known as complete blood cell examination, or CBC. And if we do that, lymphocytosis and raised ESR would be seen. Now, ESR is very high in case of tuberculosis, and there will be lymphocytosis. But total WBC count may be normal. Chest X-ray is always done, and this chest X-ray shows typical finding if it is a primary tuberculosis or secondary pulmonary tuberculosis. In primary tuberculosis, there will be gone complex, and in secondary pulmonary tuberculosis, there will be cavitation. Another type of test or investigation is fine needle aspiration cytology of an enlarged lymph node, okay, or some other tissue. We can do biopsy or cytology from those areas which are affected by tuberculosis and sent to the lab, and the lab will exactly tell us what is happening there. Okay, what is happening there. So what finding will you get if you send biopsy or cytology to the lab? What is the finding? Anyone? What finding will you get? The finding is easier one, which we have just studied. Remember, granuloma, caseous granuloma will be seen, okay, especially in biopsy, because fine needle aspiration cytology has a very less amount of tissue. If biopsy is done, then definitely caseous granuloma will be seen in case of tuberculosis, which will give you the diagnosis. This is very important point. Now, we are coming towards the end of this pulmonary tuberculosis discussion. What are the causes of death in pulmonary TB? Now, look at the causes of death here. The causes of death may be due to pulmonary insufficiency, means pulmonary failure. Lungs are badly damaged and they cannot do their function. Pulmonary hemorrhage, massive hemoptysis may happen, and sepsis. The sepsis is because of other additional infection. Sometimes death may occur because of disseminated miliary TB, cor pulmonale, or secondary amyloidosis as well. So if you do not treat, tuberculosis can lead to death. And we all know how to treat TB. So which are the anti-tubercular drug? Which are anti-tubercular?
Isoniazid, pyrazamide, streptomycin.
Very good. Good. So I'm sure you already know this, and every student must know this answer.
Isoniazid along with rifampicin.
Yes. So there are first line and second line anti-tubercular drug. In the first line, we have isoniazid, we have rifampicin, we have pyrazinamide, we have ethambutol, and we have streptomycin. These are the 5.
Isoniazid along with rifampicin.
Exactly. And others are second line. So we are not talking pharmacology here, okay? So let's not go into detail. Now I still have 7 minutes time. I cannot complete this topic, but let's start, and from tomorrow I will again do this. from the slide where we have left. Okay, pulmonary neoplasia. This is an important topic from the exam point of view and from the clinical point of view as well. Now see here, we start with classification of pulmonary neoplasia. What are the types? Just have a look there. These are, okay, non-small cell carcinoma and small cell, which is also known as oat cell carcinoma. Now pulmonary neoplasia, okay, the most common one is lung cancer, and it is also known as bronchogenic carcinoma. Bronchogenic carcinoma, it's a synonym, either carcinoma of the lung or bronchogenic carcinoma. Divided into two big headings first, non-small cell and small cell carcinoma. Now the non-small cell is again divided into adenocarcinoma, okay, bronchioloalveolar carcinoma. Some of the textbook mention this bronchioloalveolar as one part of the adenocarcinoma. So even if you forget this name, it doesn't matter. Squamous cell carcinoma, very important type, and large cell carcinoma. Now some book even do not divide this into these headings. They can directly list what are the types of bronchogenic carcinoma, like squamous cell carcinoma, adenocarcinoma, large cell carcinoma, and small cell carcinoma. All of these answers are the correct one. Okay, now let's move on. Now let's talk about what is the epidemiology of this bronchogenic carcinoma or carcinoma of the lung. What are the major risk factor, okay, and what is the role of genetic mutations? Now regarding the epidemiology, okay, I like to say a little bit more here. Okay, you have already done your neoplasia discussion in third semester. Now out of the many cancers which can occur in adult, okay, this carcinoma of the lung or bronchogenic carcinoma is always in top 3, always, where whichever country you take data from, okay, and analyze, it is always in the top 3. Now it depends which year's data I am evaluating, but the common cancers in male, especially in older male, are prostate cancer, which is very common, commonest one in case of male actually, followed by bronchogenic carcinoma and other like carcinoma colon, okay, stomach cancer, esophagus cancer, pancreatic cancer, and so on. But the important point is still to come here. If I want to know what is the leading cause of death among cancer patient, leading cause of death among cancer patient, both in male as well as female, it is carcinoma of the lung or bronchogenic carcinoma. So this is a very important epidemiological point for you. It is much more common in male, there is no doubt about it, but these days even females are having it because of the increased incidence of smoking in them. And the common age group is from 50 to 80 years of age. So it occurs in older people or older age. Now one small point, if a young person comes to the hospital with cough and hemoptysis, we think about pulmonary tuberculosis. But if an older person comes to the hospital with cough, chest pain, and hemoptysis, we think about carcinoma of the lung. So this is the very important entry point. You may be wrong, but I always tell this, in medicine, more common things has to be thought first. If you think about very rare thing, like for example, which occurs in only 1 to 2%, you will be lost somewhere. You completely forget about the common thing, and that is not the sign of a good doctor. Good doctor always think about common things first, and rare things will follow automatically. Now, the important risk factors of bronchogenic carcinoma are cigarette smoking. 90% of the time, it is caused by cigarette smoking, and it is a proven fact. Okay, it is not a hypothesis. They are proven. Smoking is the cause of lung cancer or bronchogenic carcinoma. Now, this smoking may be an active type of smoking, or it may be a passive smoking. Now remember this. That's why if you do not like that environment, you can gently request your friends, can you please go outside and smoke? I don't like, I'm not comfortable here. Or if they don't like this type of dialogue or discussion, you can go somewhere else if you want to protect yourself from passive smoking. This is a very important fact. Another major risk factor is occupational exposure, like asbestosis, uranium mining, and radiation exposure. This asbestos is an important point here. And third is air pollution. Some person can develop lung cancer when they have never smoked in their life, and that may be due to air pollution or because of genetic mutation. Like see here, maybe there are presence of some oncogene like L, MYC, and KRAS, or there may be deletion or absence of tumor suppressor gene like P53 and retinoblastoma. Okay, so let me end here for today. Okay, it will stop automatically stop on its own, and I will continue in my next class. Thank you so much, guys. We'll continue tomorrow.
Thank you, sir.
Okay, thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Okay, thank you so much, sir.
Okay, so it's the time. So let's start the topic. So today I'll first talk about pulmonary neoplasia or bronchogenic carcinoma, and then we enter into the GI tract. And the first topic I've chosen is intestinal pathology. So let's do this. So pulmonary neoplasia, okay, there are some benign tumors also in the lung, but we are not too much concerned about them. The malignant one is the most important and common, and that is known as carcinoma of the lung cancer, or bronchogenic carcinoma. All of these are same term, or these are called synonym. Now, there are different types of bronchogenic carcinoma. Adenocarcinoma of the lung, bronchiolo-alveolar carcinoma. In some of the textbook, they have mentioned it as one type of adenocarcinoma itself. Squamous cell carcinoma and large cell carcinoma. And one more is called small cell or odd cell carcinoma. Now, you can directly mention the name, or you can classify like this also, the way which we have shown in the slide. Non-small cell carcinoma and small cell carcinoma, both are correct. Now, I've been talking about this yesterday regarding the epidemiology of bronchogenic carcinoma in human being. Male are more commonly affected than female because the incidence of smoking is much more common in male than female. But these days, even a bronchogenic carcinoma, even in female, is increasingly happening, probably because of increased rate of smoking in female as well. Now, if you go back to the incidence and prevalence of different cancer in male or female, bronchogenic carcinoma is always in the top 3, always. In female, probably breast cancer is number 1, okay, all over the world I'm talking about. But in some of the country, carcinoma of cervix may be very, very common, and carcinoma of endometrium and other are there. But in male, carcinoma of prostate, okay, carcinoma of bronchus, carcinoma of colon, stomach, like that will follow. But if we analyze the total population, then carcinoma of bronchus or bronchogenic carcinoma always falls in top 3. And one very important epidemiological point is it is the number 1 killer among the cancers. Now the common age group, okay, which are affected by bronchogenic carcinoma are 50 to 80 years of age. So this occurs in relatively older people. Now, major risk factors of bronchogenic carcinoma is cigarette smoking. Okay? This is proven fact. The cigarette smoking can be active, means the person has smoken by himself or herself, or it may be passive. Sometimes even the other modality of smoke can lead to bronchogenic carcinoma, like air pollution. See this, air pollution, okay, this is also important one. Now, some occupational exposure can also lead to bronchogenic carcinoma. The important one here is asbestos exposure. So this is from asbestos factory or industry. Now, one very interesting point is here. If a person smoke and also predisposed to asbestos, then the chance of bronchogenic carcinoma is 11 times more than the person who is not exposed or who is not smoking. So these are some of the very, very important points. Now, common genetic mutations in case of bronchogenic carcinoma are, okay, you have studied this already in the basic oncology. There should be presence of oncogene, as well as there should be inactivation of tumor suppressor gene. Then only the malignancy can develop. So in this condition, L-MYC, okay, L-MYC and KRAS are some of the important examples of oncogene. L-MYC is present in small cell carcinoma and KRAS in adenocarcinoma of the lung. Whereas the two important tumor suppressor gene, which you already know, P53 and retinoblastoma gene, they should be mutated or they should be inactivated. Now, most of the students have joined, okay, till now, I'm sure about it. So let's talk about clinical features of bronchogenic carcinoma. Now, what are the important clinical features? See here, the person is relatively old, okay, more than 50 or 60-year-old. So that person cough with sputum production. This is called productive cough, cough with sputum production. Now the color of this sputum varies. If it is associated with secondary bacterial infection, it may be yellow, and usually there is hemoptysis along with cough. This is a case of malignancy, so significant weight loss would be there. The person, okay, develops anorexia. Anorexia means loss of appetite, and there is fatigue. Now this fatigue or fatigability is because of anemia. Anemia is very, very common in malignancy. Other set of clinical features may be dyspnea. Dyspnea or difficulty in breathing. Okay, we already talked about hemoptysis, that is coughing out blood, and chest pain. Now, if an older person comes to the hospital with dyspnea, okay, come to the hospital with dyspnea, hemoptysis, and chest pain, without any doubt, okay, I always think about a bronchogenic carcinoma. Though maybe we are wrong, you know, but nevertheless, the common thing has to be thought first. That is the job of a doctor. The uncommon things will follow common things. Now, some of the other clinical features may happen in bronchogenic carcinoma, and these are because of obstruction. Now, remember, malignancy is a mass, okay? It's a tumor. So this tumor may give obstruction or may compress some of the structure in the nearby area. So it may result in focal emphysema. Now, how do I explain this? This emphysema is not that emphysema which we have covered in COPD. In that case, you know, the mechanism is completely different. Here, this emphysema is because of obstruction of a small airway. Now, the area which is supplied by that airway, you know, if it is partially blocked, think about this. If it is partially blocked, okay, like a ball valve effect, so only one way flow can be there. So only air is coming in that area, but it is not going outside. Now, that can easily lead to dilation of that particular area. This is called focal emphysema. So it depends on how big is the mass and what it is causing obstruction. How big is the mass and what it is causing obstruction. If that mass completely block that airway, then atelectasis will occur. We already talked about that. Okay, then atelectasis will occur. Atelectasis means collapse. Now, can you tell me what type of collapse is that? What is the name of that collapse? Anyone?
Alveolar collapse.
No. Wait, we have talked about 4 types of collapse, right? Resorption collapse, compression collapse, contraction collapse, and diffuse type of
Obstruction.
collapse. So which one is this? Obstruction or resorption collapse? Okay, they are same thing. Obstruction or resorption collapse. Don't forget that. So this neoplasia or tumor is leading to obstruction or resorption type of atelectasis. Now, third point, which may be caused by obstruction, is bronchiectasis. Bronchiectasis, it is because of chronic obstruction. Now, in the topic of bronchiectasis, I have already explained this. The secretion from the airway cannot be drained. They will attract infection. And if that infection becomes chronic, we can have bronchiectasis in that area. Another is pneumonia. Pneumonia is just the infection of that parenchymatous area. Now, let's talk individually about each of the malignancies in the lung. Okay? Now, see here, the adenocarcinoma is almost present in 40% of the time of lung cancer. Means if I evaluate 100% of the lung cancer case, about 40 of them comprises of adenocarcinoma. Male and females are equally affected. And a very interesting fact here, this cancer is less closely associated with smoking than the squamous cell carcinoma. So you must have heard about this fact. Even the people who never smoked in their life have suffered from bronchogenic carcinoma. So usually these type of cancers are adenocarcinoma. Probably some other pathogenetic mechanism is responsible, like genetic mutation. Sometimes if a lung has chronic disorder which can result in extensive fibrosis or scar formation, from that scar a malignancy may develop. Now we call it scar carcinoma, and that is also adenocarcinoma of the lung. Okay, so these are some of the important points. Now, regarding the gross and microscopic feature of adenocarcinoma of the lung, okay, the adenocarcinoma is mainly present on the peripheral area and it draws pleura inside. So that is called pleural puckering. Okay, it is drawing pleura inside. So this is pleural puckering, and on the gross examination that mass looks grayish white, probably because of some areas of necrosis and calcification. Frankly speaking, necrosis area look black, but that is a hallmark of malignancy. A malignant mass rapidly grows, so some of the area may not receive enough blood supply, and there are some very immature capillaries also. So those immature capillary will rupture, leading to hemorrhage. So that area looks relatively red. The ischemic area look relatively grayish white, and the necrosis area looks relatively black. So these are very important feature of malignancy. Okay, don't get confused. Regarding microscopy, the tumor forms gland, because this is adenocarcinoma. Okay, it's a gland forming tumor, and it also produces mucin. So these are important points. Now the second in our list is squamous cell carcinoma. So let's talk about it. Now, squamous cell carcinoma comprises almost 30% of the lung cancer. These days, adenocarcinoma has taken over as the most common one, but it depends. I already told you, it depends on which country data you have taken. Okay, so it may vary. So both are quite common type of lung cancer. You can understand like that. This cancer is very common in male than female, and it is strongly related to smoking. Smoking plays a huge role in the development of squamous cell carcinoma. Now, this mechanism or pathogenesis, every student know. In the beginning, the person smokes a lot. that smoking causes transformation of respiratory epithelium into squamous epithelium, which is called metaplasia. It is caused by chronic smoking. Now, over a period of time, it changed into dysplasia now. Okay, dysplasia means disordered, organization of cells there. Some are big, some are small, some are big nuclei, some are small nuclei. Now, the another stage is carcinoma in situ. The basement membrane is still intact. The malignant cell have not crossed basement membrane. This is called carcinoma in situ. And once the basement membrane is invaded, we call that invasive carcinoma. So this is a very, very important knowledge for you. First, metaplasia because of chronic smoking, then dysplasia, carcinoma in situ, then invasive carcinoma. This is a very, very common mechanism in squamous cell carcinoma. Now, according to gross and microscopic morphology, this squamous cell carcinoma is present towards the bronchus. Okay, somebody is unmuting, so please mute yourself back because it is causing a little bit disturbance. So it is centrally located, okay, towards the bronchi, and it is also gray-white in color. Just like I told you, many of the malignancies are gray-white. Now, what is the difference? Adenocarcinoma is peripherally located towards the pleura, whereas squamous cell carcinoma is located towards the hilum or towards the bronchus. Regarding the microscopic exam, it has invasive nest of squamous cell. Okay, these squamous cells are flat-looking cell. Okay, there is desmosome present in squamous cell. This desmosome means they are the connecting material or connecting bridge between the cell. So mainly these epithelial cells, these squamous cells are type of epithelial cell. They attach with each other with some connecting substance or bridge, which is called desmosome. So they are very common in this type of cells. And one very, very pathognomonic feature of squamous cell carcinoma is they produce keratin. Okay, they produce keratin, which is called squamous pearls, and we can notice them under histopathological examination. Okay, so let's move on. Now, another type of after squamous cell carcinoma, okay, let's see the picture first, then we'll move on to the another side. See here, this is a beautiful picture. Okay, beautiful for us, not so beautiful for the patient, isn't it? This patient is having huge malignancy here, but for a medical student and doctor, we got a very good specimen. Now, see this. So this is trachea. Okay, this is trachea. It is divided into two bronchi. Okay, right and left. Now, because of the malignancy, the anatomy is distorted. Okay, so don't go after the anatomy here. It is a little bit pulled on that side. Now see this mass here. Okay, see this mass, this whole mass. Just follow this marker here. Okay, the pointer I should say. See this. This whole area is malignancy. This whole area. This is probably the normal lung. But this gray white mass towards the hilum of the lung, in this case, is squamous cell carcinoma. We can just guess this is a squamous cell carcinoma, but the confirmation is done by biopsy and then histopathological exam. They have already done that. That's why they are showing this picture. Now, after squamous cell carcinoma, another type of malignancy under bronchogenic carcinoma is small cell or oat cell carcinoma. This oat cell is a very commonly used synonym. Now, they are very important from the exam point of view. I'll explain you why. This cancer comprises of 20% of the lung cancer, and males are more commonly affected than females. again, they are very strongly associated with smoking. Very strongly associated with smoking. Okay, so let me highlight and teach you very strong association with smoking, just like squamous cell carcinoma. And one very important point is they are very aggressive malignancy. Within a short period of time, they can rapidly grow and they have wide metastasis. Okay. Now, can anybody tell me what is metastasis?
Spreading of tumor from one side to another.
Okay. Yes, you're right. Spread of tumor from one side to another.
Metastasis is the growth of tumor from one organ to another organ.
Exactly. Okay. Very good. So that can happen through three important pathways. One is lymphatic pathway, another is hematogenous pathway, and third is transcoelomic pathway. This can occur inside the abdomen mainly. So in other part of the body, you just remember lymphatic, hematogenous are the two main way of metastasis from one area to the other. Now let's talk about gross and microscopic examination. Now if we do gross examination, just like squamous cell carcinoma, it is also present toward the hilum. We call it central, and it looks gray-white as well. During microscopic examination, this is a very important feature. It is a small rounded tumor. A small rounded tumor. There are so many other tumors which are small and rounded, like lymphoma, especially non-Hodgkin's lymphoma, neuroblastoma, okay, retinoblastoma, medulloblastoma. All of these are small rounded tumors. So this comes as a differential diagnosis for a small rounded cell. So let me write it. Okay, we have a bit of time. I can manage this type of discussion. So let me write what are the differential diagnosis of a small round cell. Okay, now NHL, non-Hodgkin's lymphoma is one of them. Neuroblastoma is another common tumor in children. This is another one. Retinoblastoma, okay, retinoblastoma, the tumor or the malignant tumor which arises from retina. And medulloblastoma, it's a type of brain tumor. So all of these are called small round cell tumors. Now, what we see in electron microscopy, now this gives us a very important idea why this malignancy is very important from clinical point of view. Now see here, there are cytoplasmic granules, okay, which are neurosecretory granules, and they secrete a lot of neuroendocrine hormone. Because of this neuroendocrine hormone release or secretion, there are lots of paraneoplastic syndrome in this malignancy. So for example, they may secrete, okay, they may secrete ACTH, they may secrete ADH. Okay. Now, if ACTH is secreted in increased amount, what will happen? Any idea? Okay, probably nobody taught you about endocrine. Okay, so we'll talk about this sometimes later. Don't worry. ACTH means adrenocorticotrophic hormone. When a tumor produces that, it will stimulate the adrenal gland, and adrenal gland will secrete cortisol hormone. Cortisol is glucocorticoid. So excessive glucocorticoid will give rise to Cushing syndrome. So that Cushing syndrome is an example of paraneoplastic syndrome in this case. This is a very important example. Now look at this picture here. Now see here, this is a histological appearance of lung cancer. Okay, this is a well differentiated squamous cell carcinoma with showing keratinization. This is called keratinization or keratin pearl, a rounded structure which looks pinkish under the microscope. And these are gland forming cells. Look at the lumen of the gland and the walls. Okay, this is wall of the gland, which are a relatively tall looking columnar cells. So these are called adenocarcinoma. This is squamous cell carcinoma, a keratin pearl. This is gland looking like structure, adenocarcinoma. Now the small cell carcinoma are also shown here. These are small blue rounded cell. Small blue rounded cell, small cell carcinoma of the lung. And these are large cell carcinoma. The nucleus look quite big in size. Large cell carcinoma. So they are the four main type: adenocarcinoma, squamous cell carcinoma, small cell carcinoma, and large cell carcinoma. Now let's move on. Now this is the cytology of sputum. Okay, they have collected sputum, and then that sputum is studied under the microscope after certain staining, and they have found these relatively flat looking cells. Okay, it is a squamous cell which is present in the sputum. So if this type of finding is there, then we can say we are lucky. We can diagnose this type of cancer quite early, because these people usually have cough with sputum production, and when we analyze the sputum by cytological exam, if we get a malignant cell there, then diagnosis can be quite early. Now we are coming towards the end of this bronchogenic carcinoma topic. Now very important point is still left. What are the local effects of lung tumor spread, and what are the distant effects? Let's talk about the local effect first, and then we move on to the distant effect. Now see here, pneumonia, abscess, and lobar collapse can occur because of tumor obstruction of airway. Tumor is a mass. It may block the airway, it may compress the airway. So all these clinical features would be there. Quite easy to understand. Now, another is lipid pneumonia. This lipid pneumonia can also occur in tumor obstruction, and this is the name comes from accumulation of cellular lipid in foamy macrophages. Okay, so when this foamy macrophages means these macrophages have fat droplet inside. So collection of these foamy macrophages leads to lipid pneumonia. Not very important term. Nobody is going to ask you about this. There are so many other important things to ask about, like pleural effusion, collection of free fluid in the pleural cavity, and this occurs because of tumor spread into the pleura. Very important feature of malignancy of lung. Hoarseness of the voice. Now hoarseness means the quality of voice is affected. Okay, the quality of the voice is not normal. This is hoarse voice, and this occurs when recurrent laryngeal nerve is damaged. Now recurrent laryngeal nerve is a branch of vagus nerve, so it is present right there, in the thoracic cavity. Now a little bit anatomy about recurrent laryngeal nerve for you. Probably you have forgotten. There are two recurrent laryngeal nerve for us, right and left. On the left side, it is encircling the arch of the aorta and then go upward to supply the larynx. On the right side, it encircles subclavian artery and then go upward. That's why it is called recurrent laryngeal nerve. Now it can be easily damaged by the malignancy and local spread of the malignancy. Now dysphagia means difficulty to swallow. If esophagus is invaded or esophagus is pressed, then dysphagia can happen easily. Then dysphagia can happen very easily. Now another is diaphragm paralysis. Now, phrenic nerve supply our diaphragm, and phrenic nerve originates from C3, C4, and C5. Now, that phrenic nerve is quite a long nerve. Remember that C3, C4, C5 are in the neck area. The diaphragm is a muscle or dome-shaped structure which is separating thoracic cavity from abdominal cavity. So, phrenic nerve has to pass a long distance to reach the diaphragm. On the way, if there is a malignancy of the lung, it may damage phrenic nerve, resulting in diaphragm paralysis. Now, what happens if diaphragm is paralyzed? Yes?
No inspiration.
Exactly. Patient cannot breathe, isn't it? Respiratory failure will occur. And this patient may die because of diaphragm paralysis until and unless we keep the patient under ventilator. Now, destruction of the rib occur because of chest wall invasion. Okay, rib can be destroyed. This is a feature of malignancy, local invasion. Superior vena cava syndrome, SVC syndrome, superior vena cava syndrome occurs because of compression of superior vena cava by the tumor. Now, superior vena cava has important function. It will drain the blood from our upper part of the body, that is head and neck and the upper limbs. So that is obstructed now, which results in collection of blood in that area. Okay, the face looks very red because there is edema of the face. Brain will also suffer. There is cerebral edema because the venous outflow from the brain also cannot be coming towards the heart. Horner syndrome can occur if sympathetic ganglia is invaded and damaged by the tumor cells. And Horner syndrome is a constellation of 4 clinical features together. Anybody can tell me what is Horner syndrome? Have you heard this term before? Anyone?
No, sir.
Okay, no problem. Okay, problem. You can write because this is an important knowledge.
Horner syndrome is a destruction of pathway from the face and eyes to the one side of the body.
Okay, so let me explain. Okay, because this is a little bit new knowledge for you and it is a bit interesting also. So the 4 features I'm going to write about Horner syndrome. First is called meiosis. Okay, meiosis, that is constriction of the pupil is called meiosis. Second, anhydrosis, lack of sweating in the forehead and the face area. Okay, lack of sweating in the forehead and face area. Now, third is ptosis. Okay, ptosis. Ptosis means drooping of upper eyelid. The upper eyelid is drooping downwards. That is called ptosis. And the last one is called ophthalmos. Ophthalmos. That means the eyeball is going inward. Okay, it looks like a shrunken eyeball. So these are the 4 features of Horner syndrome, and they occur because of the damage of sympathetic neuron in that area. Now, another important local effects is pericarditis or cardiac tamponade, and that occurs because of pericardial involvement. Now, cardiac tamponade or pericardial tamponade is pressure effect to the heart. Okay, let's go to the another one. The last slide regarding the carcinoma of the lung. These are called extrathoracic effect of spread. Means the tumor is going outside the thoracic cavity now, or outside the lung. It may go to the adrenal gland in about more than 50% of the times. It may go to liver, brain, and bone. This is called metastasis, and it badly damages those organs. Now, I already told you about paraneoplastic syndrome. They secrete some of the substance or some of the hormone which can cause clinical feature far away from its origin. Like tumor is inside the chest, but this clinical feature can occur far away, and these clinical features are not caused by metastasis. This is called paraneoplastic syndrome. So they are mainly endocrine or metabolic syndrome, and these are the example for you. Adrenocorticotropic hormone can result in Cushing syndrome. ADH, okay, antidiuretic hormone, can result in syndrome of inappropriate ADH secretion. Means there is excessive ADH now inside the body. This is parathyroid hormone, which results in hypercalcemia, and this is mainly seen in squamous cell carcinoma. All others are more common in small cell carcinoma. And the last one is a type of clubbing, and this is a grade 4 clubbing or very severe type of clubbing, where there is new bone formation in the periosteum near the wrist joint. There is clubbing and arthritis as well. So these are important feature of paraneoplastic syndrome, which occurs mainly in small cell carcinoma, but it also occurs sometime in squamous cell carcinoma. Now, out of them, if they ask in MCQ exam, you can pick hypercalcemia